So the West African College of Physicians was established in It was established in 1976. By the end of the program, we'll tell you what we'll be doing for our 50th anniversary next year. So it's an association of medical specialists, and there are 6 disciplines under the West African College of Physicians. We have community health, family medicine, internal medicine, laboratory medicine, pediatrics, and psychiatry. So when the college started in 1976, it was mainly English-speaking country. And it was Ghana, Liberia, Nigeria, Sierra Leone, and the Gambia. So these 5 countries hosted the college, and it ran for many years. But in recent times, the college has spread into Francophone countries. And we now have 8 countries that have joined us. So we have the Benin Republic, we have Burkina Faso, Côte d'Ivoire, we have Guinea, Mali, Niger, Senegal, and Togo. And you realize that I'm always mentioning these countries in alphabetical order. I mentioned the faculties in alphabetical order. So it's the culture of the college where everything we do, we kind of follow things in alphabetical order. So what does a college do? We aim at advancing high quality physician training. We also promote ethical professional practice and improved healthcare across the West African sub-region. We also set standards for specialist accreditation. We support governments and health organizations with expert guidance. We also collaborate with relevant bodies and promote research and knowledge through scientific publications. We also have extensive collaborations with other organizations throughout the world. For example, the Royal Colleges of the United Kingdom, South African postgraduate colleges, the American College of Physicians, then the West Africa College of Surgeons, and then, of course, the Ghana College of Physicians and Surgeons. So what does the Ghana chapter do? Currently, we have 217 members in good standing. We do scientific meetings, business meetings. We did different training programs. And every year, we organize examinations in April and October. Other activities we do are that we have what we call a commemorative health day. And on this day, one faculty of the college would come up with a program that will highlight an aspect of our healthcare challenges in the country. So this year, for example, the Faculty of Community Health chose a topic global trends in improving the quality of maternal newborn care in Ghana. We do apart from the commemorative health day is public lecture. I think our first public lecture was way back in 2015. And interestingly, the topic was illegal small scale mining. We solved it. And this year we have another topic. And that year, I think it was Faculty of Family Medicine that did that. And this year we have Faculty of Internal Medicine. So I'd like to congratulate the Faculty of Internal Medicine for organizing this event on behalf of the chapter. I also warmly welcome everyone to this public lecture, and I'm confident that the insights shared today will be enriching for you all. Thank you very much. So now I have the responsibility to introduce our chair for this event. Our chair is a very unassuming person. When you meet him and you don't know who he is, you cannot know who he is by how he looks like, how he talks, and how he relates. You just can't know. So when he leaves you and people tell you that, oh, he's like this, or he's like that, so, oh, really? That's the kind of person that he is. He has been the vice, he sat in this chair that I'm sitting in before. He did 2 terms for 4 years. And then currently the Provost of the College of Health Sciences of the University of Ghana. Very recently, he doesn't say much, but he received an award from Dubai somewhere for some of the work that he has been doing, promoting and supporting them in their medical education. So we have a very big person, very unassuming person, very qualified person to chair our program today. So ladies and gentlemen, let's welcome Professor Alfred Edwin Yawson.
Thank you, Vice President of the College and Chairman of the Ghana chapter of the West African College of C. So I deem it a great honor to chairing this important assignment. Happy to see and other important policy agencies. Comprehensive healthcare financing for every Ghanaian, a Mirage for reality. So briefly, to put everything in context for this issue, I would say that financing healthcare continues to be a challenge for low, middle, and even high income countries. And it would be interesting for you to know that these low income sectors suffer more than 50% of the global burden of disease. And you know how much in total we spend over mental health, less than 5%. So you see, you come wanting to your money take, and you need to do that. For us in Ghana, we introduced the National Health Insurance in August 2003 in Parliament. And our National Health Insurance is a social type of insurance. And being a social type of insurance in a low, middle income setting like ours has some systemic challenges. Because generally, income levels are low. There is preponderant proportion of the population in the informal sector. So even if you are going to use a tax system to finance the insurance, how many people will be able to pay that tax? And there is a limit to how much tax you can collect from those whose incomes are already low. We also have a limit to how much premium you can actually pay. Because we can increase the premium so much that we have money coming into the national health insurance. But if we did that, you are going to exclude the most vulnerable in the society, and you wouldn't be able to achieve universal health coverage, which is one of the pillars in reducing finance as a barrier to access to health. Therefore, premiums paid into the national health insurance again will interest you that it costs less than 5% of the health insurance budget by way of premiums paid, and therefore somebody must pay. Over the years, government agencies have tried to improve the national health insurance, expanding the benefit package, improving the amount of resources going to national health insurance, the uncapping, and therefore whatever money you get, how much you give it to be able. And also recently plans are underway to increase the tariff, adjust the tariff to a reasonable level that will be able to support providers. Despite all this, the national health insurance, as I said, has some challenge. There are some packages that are outside the health financing architecture of our country. It's interesting. For curative care, yes, at the primary, secondary, and some aspect of tertiary level care, national health insurance takes care of. But we need to ask ourselves, who pays for essential preventive system? Who pays for immunization? Who pays for elimination of malaria? Who pays for HIV, TB, and family planning and those public services? Who pays for it? Who also pays for the complications of non-communicable diseases? And sometimes treatment and management of these chronic conditions themselves. And therefore, these are bigger questions we need to ask, and to ensure we provide financing equity for the citizens, such that we also provide financial risk protection for the most vulnerable in the society. Ladies and gentlemen, that's why we are here this evening, to discuss some of these health financing systems. And I must add that there are changes in the global architecture for health finance, which makes it even more. We all know what is happening, especially in the US and other places, which makes it more important for us to strengthen our domestic financing mechanisms and sources to bring equity and protect the most vulnerable in our society. We are all most welcome. First, we will have the presentations, and then we will have the panel discussion to throw light to some of these issues, and at the end of the day, offer some recommendations for policymakers, government, and move it forward. My WHO colleague here was telling us, yes, this is a very good forum, but we need to probably bring all the important key persons involved. Academia, as we are doing it, Ministry of Health, National Health Insurance. It's a very good advice we have taken. And as academics, West African College, I think we can spearhead that, bring it a bigger forum, get a more listening audience, as well as government. So thank you very much. I believe we can proceed to the first aspect of our program. So Mr. MC, I'll hand over to you. I warmly accept the thank you.
Thank you very much, Chaiman, for really for the medical students and other health professionals who are carrying the high standards. This talk is at the end of the day, exam of wisdom. Okay, so now it's my honor to guide the World Health Organization country representative in Ghana, Dr. Braka, I'm very much hope to be with us this week. However, due to unavoidable scheduling, unable to in her place, however, she has graciously delegated a distinguished colleague of hers, represents her, deliver the keynote address. We are therefore honored to welcome Dr. Fiona. I hope I got your name right. He's a health systems policy advisor at the WHO country office here in Ghana. Seasoned health expert who continues to guide national strategies in health, strengthening universal health coverage, and providing equitable health care. Dr. Alfred brings a wealth of knowledge, strong commitment to ensuring that Ghana's health financing reforms are effectively aligned with global standards, the WHO's goal for resilient, full-centered health. Ladies and gentlemen, please join me in a warm applause to invite Dr. Fiona Alfred.
Thank you very much. Universal health coverage in Ghana, challenge and prospect. That is the topic of the keynote address, and I promise that the keynote address will be as short as I am. Professor Chair, distinguished members of the academia, representatives from the Ministry of Health, colleagues, ladies and gentlemen. It is indeed a privilege to address you today on this very important undertaking, which will be focusing on health coverage, its challenge and prospect. That is the topic of the keynote address. On behalf of the World Health Organization, Representative Dr. Fiona Braka, I bring warm greetings and deep appreciation to the college for convening this timely public lecture. Dr. Fiona Braka would have loved to come here, had it not been to the International Conference for HIV and STI CASA meeting, but she had to represent the regional director, and she has to sit in for that. But she has sent her greetings to all. So to start with universal health coverage. Universal health coverage is not simply a technical indicator of SDG. It's more so a moral imperative, a social contract, and a cornerstone for national development. This target for sustainable development goals calls for every country to ensure that all people can obtain health services, or all health services people need, of sufficient quality without suffering financial hardship. So we are focusing on three things. One, service, quality service. Two, people, everybody accessing the service. And three, the point that we have already started discussion, financial risk protection for all the people. Yet, globally, the picture, when it comes to progress towards universal access to health services, the numbers are sobering. More than half of the world's population still does not receive essential health services they need, and close to 2 billion people experience severe financial at health services. Progress towards UHC has slowed in many regions, particularly where fiscal space is tight and competing priorities are many. Here, I take the precaution of telling you that this is dependent on this information is dependent on the global report towards UHC 2022. The data is a bit old, but it's very unlikely with COVID and so many things in the current global financial situation. It's very unlikely that the situation has dramatically improved. The progress towards UHC slow. The UHC coverage index in many countries around 50%. Ghana at the time around 48%, a bit better than many African countries, but then still low. Africa's challenge is especially acute here. Our continent faces double burden of disease, I think clear for you. I mean, communicable diseases and non-communicable diseases. But this pressure is compounded by a number of issues. Climate-related shocks, macroeconomic volatility, migration of health workers to more affluent economies that we might migrate in the coming few years. With West Africa, Ghana reflects many of these trends. The population is growing, epidemiological profile is shifting, there's growing burden of non-communicable diseases, and citizens' expectations for timely, quality, and high quality and dignified care is increasing. Against this backdrop, the central question of this lecture is comprehensive healthcare financing for every Ghanaian a mirage or a reality is both timely and indeed urgent. Now I will move to the heart of the topic of the keynote address, which is universal health coverage, its challenge and prospects. And I will start with the progresses and the pressures that we are facing as a background before going to the prospects and the challenge. So what are the progresses? There is a strong but uneven foundation for UHC. You know, it's important to begin with recognizing that Ghana has the distance Ghana has come. Over the past 2 decades, the country has made significant gains in health outcomes. Maternal mortality has declined more than half since the year 2000. Well, we may need to put a pinch of salt on this because I will come later with the issues that we have with this indicator. Under 5 mortality and other indicators has shown significant improvement. I will not go to the details. But this includes significant improvement in life expectancy. And there is also significant achievement in terms of strengthening the primary health care system, specifically the community health planning system, which made sure that basic services, reproductive, maternal, newborn, and child health services, and treatment of communicable disease are available to the lowest level of the health system, which has significantly improved the coverage and outcome interventions to many of the basic health problems. Ghana has also shown resilience in the face of public health emergency. The response to COVID and to threats like Marburg, Lassa fever, cholera, the ongoing smallpox, all have demonstrated that when adequately supported, the system can mobilize adapt, and innovate. Indeed, the response and the ability to contain a number of public health emergencies has been really appreciated. Moving forward, Ghana's health financing landscape. What are the progresses? What are the pressures here? On the financing side, Ghana has built one of the more advanced architectures in the region, but it's under real strain, and it is already mentioned. The National Health Insurance Scheme, which remains the flagship mechanism for financial risk protection and the main purchaser of services at the facility level. It currently covers just over half of the population, I think 56% if I'm not mistaken, and has progressively expanded its benefit package to include a number of issues. Childhood cancers, family planning, elective mental health conditions, and innovations such as digital technology, mobile renewals, automatic enrollment for SSN IT contributions, and fee waivers for vulnerable groups reflect strong commitment to equity and access. At the same time, the broader public financing picture shows both progress and gaps. Let's look at this. Government expenditure, Ghana, has increased 8.7% of the total government expenditure. Looking at the past expenditure, I think this is the highest that we have recorded. But it's short of what is required in the Abuja Declaration, if we take the Abuja Declaration as a target. And then, as a percentage of GDP, the maximum amount of money that was spent was 4%. Well, ideally 5% is recommended for availing basic primary health care related services. So there is an area for improvement. The share of out-of-pocket payment, it was around a third some years back. Recently, the finding is that a quarter of the total health expenditure is out of pocket, which means still significant amount of money that is spent on health is out of pocket of individuals going to the health facilities, and this is an area for still improvement, even though the improvement that's already there is appreciable. Government investment on primary health care. It is 50% of the total health expenditure in health. This is an important area for improvement. For UHC, the recommendation is that around 80% of the total expenditure for health should go to the primary health care. On the positive side, Ghana has taken bold steps to expand domestic fiscal space. The uncapping of the National Health Insurance Levy was done recently, together with the 2.5 percentage point earmark from SSNIT, has created additional room for health spending. The expansion of excise tax on alcohol, tobacco, and sugar sweetened beverage has increased revenue. For example, annual cigarette excise recipients have grown several-fold in recent years. These moves show that when there is a political will, domestic resource mobilization for the health is possible. The amount of resource that was mobilized from cigarette excise might not be very significant, but at least it shows the possibility and the chance of mobilizing more resource for alcohol and from alcohol and sweetened beverage. But the uncapping of the NHIL is really clear policy move that increase the flow of resource to the health sector. Now, another progress, new reforms, free primary health care and the Ghana Medical Trust Fund. Building on these foundations, Ghana has embarked on two major reforms, the free quality-focused primary health care and the Ghana Medical Trust Fund. Both initiatives are aligned with Ghana's health financing strategy, the UHC roadmap and regional goals, such as the Lusaka agenda and the emerging health sovereignty agenda for countries to reduce excessive reliance on external aid and to chart their own sustainable financing pathways. As you know, the free PHC is about availing free basic health services at the lowest level of the health sector, possibly at the CHIPS and health centers level, free of charge. And the Ghana Medical Trust Fund, also known as the Mahamas Care, is about decreasing the financial burden for highly specialized interventions for chronic diseases like possibly including renal failure, cardiovascular diseases, and complications of hypertension and cancer. However, both these initiatives carry the risk that must be carefully managed. The free PHC scheme is still in the process of having its policy framework and implementation roadmap finalized. Well, if it's finalized, we will hear from the Ministry of Health, but to the best of the information that we have, it is still ongoing. We hope the key policy issues will be fully addressed by then. In relation to the Ghana Medical Trust Fund, key elements such as the operational framework, revenue resource beyond the National Health Insurance Scheme, and integration with existing purchasing arrangements are to be defined in the near future. We hope the decisions being made in this front will avoid duplication, fragmentation, and improve efficiency, as that still remains the concern. Now, the challenge where the Mirage still looms. Despite these advances, Ghana's journey towards PHC faces serious headwinds. Let me highlight some of these points that are critical. One, financing and sustainability. Public allocation to health, while improving, remains below what is needed to close coverage gaps and sustain expanded benefits. The current budget allocation, 3.2% of the total government health budget, 6.32% of the total government budget is allocated for health, even less than the 8% that we had some years back. This is below the Abuja Declaration, which is 15%, and declining and fragmented donor support, coupled with high public debt burden and macroeconomic volatility, squeeze fiscal space. At the same time, underspending and delayed release for goods and services at various levels of the system weaken service delivery. The second issue is the issue related to human resources for health. Coming from the academia, I think you are very much versed with this. I mean, tens of thousands of health professionals remain unrecruited. At the same time, there is attrition of health workers from a number of areas, particularly the hard-to-reach areas. So this will affect the quality of service, which is one of the pillars for universal health service. And then the service delivery gaps. Despite the progress, avoidable maternal and newborn deaths persist. Particularly if you look at institutional maternal mortality, the decrease is quite concerning. There has been decrease in the past 2 decades, but particularly if you look at the 6-7 years, institutional maternal mortality almost stagnated. Does it translate to population-based maternal mortality? Most likely, we cannot be sure, but that's likely to be the case. Immunization coverage, even though very good in Ghana, is not uniformly high across all districts. The rapid surge of non-communicable diseases is straining facilities that are often designed and staffed for acute rather than chronic care. Infrastructure deficits and stalled projects in some areas continue to limit access, especially for rural and peri-urban communities. And another challenge is supply chain and medicine. Procurement and supply chain arrangements remain fragmented with parallel systems for different programs and funding streams. This is mainly about an issue of efficiency. Reliance on donor support for key commodities, such as family planning methods and macronutrients, create vulnerability. Stockouts at facility level erode public confidence and drive people into private markets where they often pay more out of pocket. And this, at times, had extended to the very critical intervention of immunization, I think, the previous year. And then governance and integration, another area of concern. Fragmentation between purchasing mechanisms is a potential challenge that needs to be addressed at this particular moment. Unless purchasing mechanisms are deliberately aligned within a unified financing and service delivery architecture, anchored in the essential health services package, or whatever service package, whether the national essential health service delivery package or a new package that we prepare, resources can spread thinly, data systems may become incompatible, and populations may face confusing and unequal entitlement. Then, from challenge to prospect. What should be the priorities going forward? The good news is that none of these challenges are insurmountable. With decisive action, they can be transformed into opportunity. Allow me to outline in a very concrete way some key priorities that can help move Ghana from the risk of a mirage to the reality of comprehensive healthcare financing. One is increase and protect public financing for health. Ghana will need to continue moving towards the Abuja commitment over time, not through abrupt jumps, but through sustained incremental increase, strengthened budget execution, and better protection of health budgets during fiscal adjustment. This definitely should be done hand in hand with improving the efficiency of utilization of resources that are already allocated to health that I will allude to later. The second one is making primary health care the centerpiece of universal health coverage. Free PHC, the idea that is being operationalized currently, needs to be fully costed, phased, and aligned with a clear service package agreed by all stakeholders. Clarifying what services are included, where they are delivered, how providers are paid, and how quality is monitored will be critical. Well, these are the components of the policy that we are waiting to look forward. Increasing the share of total health spending devoted to PHC towards the recommended levels will yield substantial returns in mortality, morbidity, and financial risk protection. And the third one is operationalize the Ghana Medical Trust Fund in a way that complements the already existing national health insurance scheme. This also means aligning its provider payment mechanisms, medicines list, data systems, claims management, and accountability frameworks with those of NHIs and free PHC, while maintaining clear ring fencing for its strategic objectives should be, and this should get the due attention of the policymaker. And the fifth one is improving efficiency, governance, and data use. Here, strengthening public financial management, reducing leakage, improving procurement and supply chain management, and using data for strategic purchasing are all essential to ensuring that every cedi spent in health delivers maximum value. Our ability to mobilize more resources from Ministry of Finance or any other sector is dependent on our ability to use each and every cedi at our hands and deliver on that, and prove that whatever comes will be used efficiently. And then innovative financing partnerships. There is an urgency to mobilize private and philanthropic investments for health to help bridge funding gaps, improve efficiency, and foster innovation in service delivery. With this, what is WHO's partnership with Ghana? Well, WHO has been a long-standing partner in Ghana and its path towards UHC. WHO will continue to support the implementation of the health sector medium-term development plan, the UHC roadmap, and the health financing strategy, and all other initiatives. We also stand ready to assist and finalize the operationalization of the policy framework for the free PHC and the Ghana Medical Trust Fund, and we are already supporting the government in this area. WHO will also continue to work with the Ministry of Health, Ministry of Finance, Parliament, NHI, Ghana Health Services, professional bodies, civil society, development partners in the academia to align external support behind national priorities, reduce fragmentation, promote accountability and learning. Ghana has already shown appreciable leadership in convening continental dialogues on health, sovereignty, and domestic finance. We believe the country can equally become a practical demonstration site of how to translate these principles into sustainable reforms. If you remember, there was the Health Sovereignty Summit that was held in Ghana, I assume in August, where a number of heads of nations of different African countries came and deliberated on the current global health funding architecture. And that was a great initiative by the President of Ghana, amongst other African leaders. In conclusion, universal health coverage becomes a mirage when financing is fragmented, when reforms proceed in isolation, when inefficiencies are tolerated, and when difficult but necessary decisions are postponed. But UHC becomes a reality when financing is coherent and predictable, when primary health care is prioritized, when health workforce is fully engaged and motivated, when government is strong and transparent, and when the service package truly guides what every Ghanaian can expect from the system. Health is not, in our view, a cost to be minimized. It is an investment in freedom, dignity, and prosperity. The question before us is not whether Ghana can afford to move towards UHC, but whether Ghana can afford not to. With strong leadership, evidence-informed policy, and collective commitment, Ghana can ensure that no one is left behind, and that comprehensive healthcare financing becomes not a distant aspiration, but a lived reality for every Ghanaian. Thank you very much. God bless Ghana.
Thank you very much, Dr. Ashraf. I think we can do much better with our applause. Regulates our care. Dr. Divine Balubala has joined us. We also have in our midst the Dean of the University of Ghana Medical School, Professor Iwonde, and a few others that I'll be mentioning as I go along. At this juncture, whatever it is that we are doing is healthcare, and we need to get our, if you like, our overall bosses also to make a few statements with respect to what it is that we are doing. It is therefore with great pleasure that I invite Dr. Ernest Kunedu Asiedu, who is the Director of Medical and Dental Health Service and the Technical Coordinating Director of the Ministry of Health, to share some few thoughts with us before we go to our speakers. So Dr. Asiedu, if you would kindly come up and just spare us some few minutes.
Thank you. Yeah. So I first want to recognize a lot of my senior colleagues who are here. Professor Alfred, Yawson, who is the chairman for this particular program. I also see the vice president of the West Africa College, well as also my deputy registrar, my deputy college rector at the Ghana College of Physics and Surgeons. I see my registrar, who allows me to practice, Dr. Divine Banubala. I also see the representative of the rep of WHO, who just finished speaking, the General Secretary of the Ghana chapter, Dr. Collins Okro, here. I see Professor Tete, who is also seated directly opposite. See a number of senior colleagues who are here. Colleagues, Dr. Tony Sedo, formerly from the World Bank. I worked closely with him during the COVID outbreak. I see representatives from the Ghana Medical Trust Fund. I know that they would also rep on the panel, so there's going to be a lot of conversation that is going to happen. And I see an assistant commissioner from the GRA. I like the people who are here because the conversation ultimately spans not just within only the health sector, but even in terms of how we mobilize additional resources, especially in times where the global funding is also dwindling. We need to look more internally. So I see Prof. Boima from the NSOP area, and then the team within the NSOP. So I would proceed. I hope that this public lecture is also being aired virtually, because if I had missed it, I would have been very happy to also get the opportunity to watch it. But I'm not sure it was widely disseminated. If I also got it, I would have shared with a number of colleagues, because I think the conversation is very, very timely. The Ministry of Health just finished a National Cancer Forum, and a lot of the issues that Prof. Chaiman raised, especially around promoting health and things around the prevention of diseases, are very key areas that we look at. Of course, it's very expensive to provide the curative care, and so if we're able to focus more on the prevention and also the promotion component, that would be very good. So, distinguished ladies and gentlemen, I would say that it's a great honor for me to stand before a lot of my senior colleagues. I think I can also see the Deputy CEO is hiding at some place, but my eyes are spotting him. The Deputy CEO of the National Health Insurance Authority, responsible for operations. So I know that he's going to display also on the panel, because once we talk about financing related issues, I think it's very, very critical. So I take it as a great honor on behalf of the Ministry of Health, and also a very important conversation that we intend to look at comprehensive healthcare financing for every Ghanaian, a mirage or a reality. I must say that I see it as a reality, especially in times like this, where I see that a lot of my senior colleagues and my colleagues have the opportunity to make a lot of inputs into how the health sector needs to run. And I think that for me, it looks more a reality than just a mirage. I think currently, I'm sure NHIA may go a bit more deep into it. With the free primary health care, a lot more focus is going to be on the preventative aspect of health. Of course, NHIA has been funding a number of conditions as far as the curative care is concerned, about 95% of all known conditions that we have in this country. And then also currently, with the catastrophic health expenditure, especially related to chronic non-communicable diseases, the devastating ones, the Ghana Medical Trust Fund is also going to look at that aspect of it. Again, I must mention that health financing has become one of the most significant public health related issues, since we do know that financing is a very important area within the health space, and also it costs money to provide health services. And so especially for various chronic diseases, especially into the cancers, and all that I think Chair has also talked about, it is also very important that we give a lot of attention to that. Clearly, the revised National Health Policy 2020 sets some clear visions for a healthy and productive population for national development. And so if we are not able to take good care of ourselves, then it's also going to affect the productivity that we do have in this country. Similarly, the Ghana Universal Health Coverage Roadmap, which was done 2020 to 2030, also outlines some commitment to ensuring that all citizens have access to high-quality essential health services without any financial hardship at the point of use of the service. So clearly, it is known that health is expensive. At the same time, it's a good investment because of the productivity that goes with it, and that we all need to invest into our health system. The ministry's commitment as a government is further demonstrated through the innovative financing mechanisms and strategic initiatives. As I mentioned, the Ghana Medical Trust Fund has also been established to mobilize resources for critical health intervention. The non-capping of the National Health Insurance Fund also ensures sustainable financing for health services, including all these chronic and the catastrophic conditions or expenditure that we have. Furthermore, our quest to also introduce the primary healthcare initiative guarantees access to essential health services, including the ones that also require a lot of money. Also remember that beyond the promotion and prevention, government also has committed into the palliative care settings in addition to rehabilitation. I think a lot more focus in the past has been on the curative care, because that is the one that typically we do know that people become sick and then they can be cured or they can be managed within specific conditions. And we must also mention that, just like the WHO said, all these policies and initiatives are not just national priorities, but they are also aligned with the global effort to achieve universal health coverage and the sustainable development goals. And we must mention again that this reflects Ghana's determination to enhance prevention, promote early detection of various conditions, including various kinds of screening, and the commitment of detecting conditions early so that we could save more money in that sense. On that note, I would like to thank all of you. I'm hoping that we'll continue to have a very interesting conversation and hopefully be able to come up with some specific recommendations as the outcomes of this program. I just want to mention them. That one, we want to increase awareness of the financing challenges and opportunities in Ghana's health sector, which this gives a very good platform for us to also continuously educate our public. We also want to hope that at the end of this, we'll be able to set a policy recommendation for strengthening Ghana's health financing mechanism. And then finally, a stronger partnership between government, academia, civil society, the private sector, and all the stakeholders who are gathered here. Thank you very much.
Thank you very much, Dr. Konedo Asiedu. I think that you have summarized it very well, and it dovetails nicely into the next segment, which is to have our panelists make a 10-minute presentation before we go on and have a panel discussion and a question and answer session. I think that would all agree that Ghana is at a crossroads when it comes to healthcare financing. Indeed, for those of us who work in the clinical setting, sometimes it becomes a bit disheartening when you encounter patients who need certain interventions, medication, and they simply cannot afford it. And when that happens, we really do need to have a conversation. If indeed the universal healthcare coverage goes American. So we have assembled hard to say that having gender balance is that. But these are, if you like, the league of gentlemen who are well poised to have, a discussion on
Thank you. Sometimes solutions are just as simple as that. And I'm hoping that at the end of today, we will have solutions that will be as simple as this. But as I've said, we've gathered some extraordinary gentlemen from academia, from government, from clinicians, and people in the private sector to be able to have a discussion this evening on how to address this very important issue of healthcare financing in the country. So we will be calling them upstage. Each person would have 10 minutes maximum to give a speech, after which I will line them all up in the chairs, and then I will have some questions for them. And obviously the audience would also have their time to ask any questions that come up. Let me just say that we also have audience outside this room. These are virtual audience. And if my numbers are right, we have something north of 100 plus who are joining us virtually. And the chat box is also open for them, so they can participate by asking questions. So without much ado, I would like to invite our first speaker to the stage. And this is, and I'm going to do something a little bit unconventional. I don't like introductions. So I'm going to allow them to give us a thumbnail introduction of themselves before they give their speech. So the first would be Dr. Senanu Dzokoto from the National Health Insurance Authority. Dr. Dzokoto, welcome. So he will be telling us on the state of NHIS financing. And I'm sure that it will be very interesting considering the recent things that the NHIA has been up to. Dr. Senanu.
Thank you. Thank you very much. I had a slide to share. Are we able to bounce the slide at this moment? But let me first of all say a very good evening to all of you. And I convey the warmest regards of Dr. Victor Bampo, who is the Chief Executive Officer of the National Health Insurance Authority. He was billed to be here, but he's running some assignments for the President, so I was asked to stand in for him. Let me also especially acknowledge my esteemed board member, who is also the registrar for the Ghana Medical and Dental Council, Dr. Divine Banyubala. I don't want to lose my job, so I have to. I acknowledge the entire leadership of the West Africa College of Physicians and the very noble guests seated here this evening. I must say that I've been very much impressed with the kind of discussions that are being held, and we are extremely grateful to you. For a very long time, health financing hasn't appeared to be but you are giving us the stage to be able to further have these discussions, because quite a number of Ghanaians are not getting access to health care because of the cost that is involved. But as a country with one of the best social health insurance schemes, we think that we should actually set the pace when it comes to health financing here. So I've been given 10 minutes. I'll do a very quick introduction. If I can have the slide pointer, or you'd regulate it from there. Can we go to the next slide? Yes, so I'm the Deputy CEO Operations for the National Health Insurance Authority, what I do is to basically supervise all the operational activities of the National Health Insurance. It's quite a big organization. We have a number of directorates, from quality assurance to claims, claims processing to operations. Then we also have what we call the strategic health purchasing directorate, something that I'll speak on very soon. I hope you can all see the slide. So this, because it's only 10 minutes, I have very compact slides that I'll speak to, and I would be done in no time. Luckily, Dr. Astrat has spoken to most of the issues. I think his lecture basically summarizes everything. I'm wondering why we are even continuing with the engagement. But I'll quickly just re-emphasize a few points. So when it comes to revenue mobilization for health financing, it is the responsibility of finance. They lead the charge for revenue mobilization for the Republic of Ghana. So usually this is through direct taxes, social security contributions that we all pay, then from the indirect taxes. So specifically for health, we have the National Health Insurance Levy, where there are taxes on commodities that are seen to be enablers or facilitators for non-communicable diseases, but we don't have that in Ghana at present. Then it is not very significant, the insurance premiums that we pay for the National Health Insurance Scheme, but it is worth mentioning. So basically, that is for the revenue mobilization, which is the responsibility of the Ministry of Finance. Then when it comes to the pooling of funding, you see that the Ministry of Finance usually supports the Ministry of Health directly. Thankfully, Dr. Asiedu and Esconedo Asiedu is here. He would attest to that fact. Then we have the development partners. So they support in two ways. We have what we call the on-budget support and the off-budget support. So on-budget support means that they'll give the funding to the Ministry of Finance. We have a few of such programs running. The Performance for Results program, they give the money to the Ministry of Finance, and then they disburse. Then we have statutory funds that goes to the National Health Insurance Scheme. And I know that all of you know 2.5% of VAT, and then 2.5% of our SNIT contributions. And then we have the insurance premiums. And we ourselves also judiciously manage our funds, and we have some to keep in investments. So that also brings us some returns. Then we have the private health insurance who also mobilize from individuals who feel that, well, beyond the National Health Insurance Scheme that we have as a country, they can also be able to add on. And then when it comes to service provision, Dr. Asrat spoke about the strategic purchaser. And in Ghana, it's the NHIS that is mandated to be our main strategic purchaser. So we define the benefits package. So what goes onto the National Insurance Scheme? So we say 95% of the disease conditions. What is significantly missing at this point is the preventive, promotive health interventions that are not on our benefit package. We also decide the kind of payment method that we use. So at present, we use two kinds of payment methods. The first one is the itemized billing or itemized cost for the medication. So if you are involved in claims processing, you'd have noticed that for every medication that you give, we have a price list and we pay for it. And then the second one is what we call the Ghana diagnostic related groupings. We are the first in Africa to develop our own Ghana diagnostic related grouping. So similar conditions that would cost about the same to render or like for service provision they are grouped together, and then the facilities would see, raise claims, and then we would pay for it. And then we also have a responsibility to credential facilities. So who is able to be with the health insurance? All from the teaching hospitals to the secondary level facilities, district hospitals, TIPS compounds, health centers, the pharmaceuticals, some of the pharmacies, the standalone labs. We give credentialing to them, and then we monitor them to ensure that they are rendering the appropriate service. So basically, that is our role when it comes to service provision. But I've also mentioned that the development partners can also support service provision directly. So if you look at the Ghana Health Service CHAG, they have quite a number of partners who come to them directly. And the Ministry of Health is also deeply involved. And you can also see the private health insurance schemes also participating. But what is of great concern to all of us is the household out-of-pocket expenditure. I think Dr. Asrat mentioned that a quarter of our health financing comes from the out-of-pocket payments from our clients, which is not too good. About 2-3 years ago, it was about 36%, but at present, it's 25%. But we are taking steps to reduce it. And in my next few slides, I'm going to talk about it. So this takes us to the next slide. I guess I have just 4 more minutes to go. We have a few critical issues to talk about. Yes, kindly help me with the next slide. So in a snapshot, 8.73% comes from government. And Dr. Ashat mentioned that the Abuja Declaration recommends that at least 15% of your budget should go into health. We are doing 8.73% as a country. He also mentioned that the proportion of the GDP for health, that goes into health expenditure, should be about 5%. Ghana is doing 3.9%. And this is what I mentioned earlier on, the out-of-pocket payment. A very big animal in the room that we have to deal with. 25% is not too good. At present, our coverage as National Health Insurance Scheme is 20.7 million. That is up by 2.7 million, but 18 million was the figure for 2024. Because the rest of the figures are 2024 figures, that's why we put 18 million. But coverage, NHIS coverage is not equal to financial protection. That is very key. That's one thing we should note. So we cover 61% of the population now, but how adequate is that coverage? That is the big question. So that's what brings to mind the out-of-pocket payments that we have. So quickly, we can go to the next slide. So this just speaks to the total health expenditure. The blue bars, you could see this is from 2018 all the way to 2023. On the extreme left is the light blue bar, and then that red or orange. I think the ladies are better with colors. They will be able to help me. That's orange, I think. Just about 1%. That's CAPEX, capital expenditure. So equipment, infrastructure, immovable assets, that's where it is. And the rest basically is from salaries and maybe health insurance, reimbursements to facilities and so on and so forth. So there appears to be an increase from 2018 all the way to 2013. So 9 billion in 2018 all the way to 26 billion in 2023. But the next slide would reveal something that is extremely interesting. So can we go to the next slide now? Echo, next slide. Thank you. So the blue bar, or the blue line, is in cedis, our current health expenditure in cedis. So the total health expenditure is basically how much we expect to have. Then the current health expenditure is how much we actually spend. So the blue bar is in cedis. And again, the orange bar is in dollars. So if you look at the trajectory, we may appear to be spending more in cedis, but it's basically due to the devaluation of the cedi over time. 2020 to 2022, the cedi moves from 5 cedis per dollar all the way to about 17 cedis per dollar. So when you look at it that way, there appears to be an increase in expenditure, but actually that is not the case when you look at it in dollar terms. So we are still chronically underfunding health in this country, and it comes with a lot of complications. So you realize that there's a gap in the kind of quality of health services that we render, and so on and so forth. So that takes me to about my last but one slide. Echo, if you can help me with the next slide. Echo, next slide. Right. Okay, good. So the role of the NHIS. So currently, the National Health Insurance Fund has been uncapped. What it just means is that all that we were entitled to from the National Health Insurance Levy did not come to the National Health Insurance Scheme for it to use for financial protection. So this decision by the President of the Republic through Parliament to uncap the National Health Insurance Fund alone gave us an additional 3.4 billion cedis. That's an injection of an amount of money that has been very much unprecedented. And this has helped us to do key things. One of the things that it has helped us to do is to be able to establish the Ghana Medical Trust Fund, which will be spoken about by my colleague, Dr. Kipo. Then the second thing was that we were not able to pay very realistic tariffs. So let me clear this confusion, because I've seen in the media that a lot of people, when they heard that the tariffs had gone up, they said, oh, we are going to have to pay more. I mean, people think that we are going to charge more for premiums and there are going to be more taxes. No. So the tariffs actually mean that the services that the hospitals render, for instance, if you're treating malaria and we're paying you 20 cedis for it, it's gone up by 120%. So we will now be paying you maybe 444 cedis for treating malaria. So that is what we mean by the tariffs have gone up. So for the first time, we looked at all the building blocks, what that goes into our tariffs, and overall we are going to see an increase in the tariffs by 180% from the 1st of January. And its impact on claims, claims reimbursement, would be 120% because of the mix of cases, at least an average of 120%. So if a facility had 1 million cedis to deliver health service, 1 million cedis a month as claims reimbursement to deliver health service, that same facility would now be getting 2.2 million cedis to be able to fund. And that has direct implications on the quality of health care that they are able to provide. And we are hoping that this will bring an end to the illegal payments. So that links me back to the out-of-pocket payment. It's currently 25%. With this intervention, our hope is that we are able to reduce it by more than half. So next year, if we meet here, we should be talking about out-of-pocket payments less than 10% for Ghana, and that would be a very good record for us. I've talked about our role in purchasing and provider payment, and obviously, we have equity measures within the scheme. We are looking at the broad population. We are looking at inclusivity, especially for vulnerable populations. We are ensuring that everybody is covered, because for us to have a very strong health system, we should be able to take care of the most vulnerable. So if the public health experts would usually tell you that if you are not able to prevent cholera in Ketu South, in the Volta region, we are all at risk. So it is important that we protect everybody financially so that some of these epidemics will not rear its ugly head into our country's health data. So I'll go to the final slide. So this is just framing Ghana's health financing reforms, and this has really become a very popular slide in all our international engagements. They usually project it. So we are going to have the free primary health care, and because of time, let me just say that what is coming on board new is the preventive and promotive health services. If you go to CHIPS, you go to the health centers, you are not able to even check for your random blood sugar. You can't be screened for something as common as diabetes. Why not? Because who is paying for the strips? Or if you wanted to have a breast screening done or a cervical cancer screening done, you will not be able to do it at the CHIPS or health center level. But when you are able to pick these disease conditions early, then we are able to reduce the burden of some of these non-communicable diseases. That will be our focus, but we are also going to look at financing surveillance, and even as we have dwindling international funding for health, we hope to bridge that gap when it comes to the provision of primary health care. And one unique thing about this is that whether you have an NHIS card or not, you would be seen for free. So this will be global coverage for everybody. CHIPS compound health centers and polyclinics. Then beyond that is the National Health Insurance Scheme as it is, the Ghana Diagnosis-related groupings as you know it. Then the last bit is the Medical Trust Fund. I will not expatiate on that because Dr. Kipo is here to speak on that. But you all know what some of the complications of these NCDs can do. Chronic kidney disease, if you've been through managing a relative who has, let's say, prostate cancer, an advanced stage, your money will finish, and if you're not lucky, the patient will also not live for too long. And these kinds of catastrophic expenditures is what the Ghana Medical Trust Fund is going to take care of. So we are looking at healthcare service, providing financial protection from end to end. The continuum of service from preventive to promotive, all the way to dealing with some of the catastrophic health conditions that actually can have a very devastating impact on our pockets. So on this note, I would want to once again thank you all for this opportunity, and thank you all for listening. Thank you.
Oh, I'll call you. I'll call you today. Thank you very much, Dr. Dzokoto. That was very insightful and giving us an insight into the NHIS financing. I'm particularly happy that you clarified this issue with regards to the increase in tariffs, because it seemed to be a source of confusion for quite a number of people. Before I call the next speaker, it is nice that we have in our midst other royalties when it comes to the West Africa College. But before then, it is important that I also recognize the presence of Professor John Nkrumah Mills, who is, I think, the past president of the Ghana College of Physicians and Surgeons, Prof. Mills. We also have Professor Albert Apalu, who is the past Secretary General of the entire West Africa College of Physicians. I think he stepped out, so not just Ghana, but the entire West Africa College of Physicians. We also have Prof. Onike Rodriguez, who was our past VP. She preceded both Prof. Yawson and Prof. Lawson. And then, yes, we have a young old man here as well, Professor Yautete. He taught me pathology when I was a student. He's also a past VP. So I think that it is time for us to call our next speaker. And as I've already established the rule, they will give a thumbnail introduction of themselves. So, as they say, everything is about the economy. And therefore, in this particular lecture, it is good that we have a health economist amongst us to speak to some of the subjects that you are raising. So, Dr. Anthony Sedo is a health economist, and he will be talking to us on the topic, is comprehensive financing sustainable? So with a warm round of applause, please invite Dr. Sedo to the stage. Doc.
Thank you very much. Good evening. I'm still doing well. I hope you are too. Very well. Distinguished ladies and gentlemen, I stand on existing protocols to give this brief exposé rather than a lecture. So I'm going to make it a bit conversational in my own presentation. Do you have a slide or I have to? So the topic I was given today is comprehensive finance, health financing, sustainable. The speakers before me had already elaborated on many of the issues that I will have taken on. So I'm not going to belabor that so that I can be within the 10 minutes. But if you were a student, wave to me. Very good. Take out your pen and paper, ignore the rest. Because they know almost everything that I'll talk about. So what are the foundations of health financing, basically? And what makes it sustainable? Next slide, please. Introduction of myself, right? I'm just the former senior economist at the World Bank. I just stepped down as the tax team lead for Ghana, Togo, and Liberia. Thank you. All right, so what are the fundamentals of health financing and how do we get it sustainable, particularly the comprehensive financing? The assumption is that when we talk about comprehensive health financing, we are talking about universal health coverage, which borders on the entire spectrum that is made available to all people at all times at a point of need. So we talk about the preventive and primary health care, talk about specialist and specialized diagnostic services. We talk about treatment, we talk about pharmaceutical, and sometimes we talk about rehabilitating. But we don't talk about it very much. Then we also talk about all these services being available equitably. It means that they are fairly distributed across the board. And geographically, wherever you are, you should be able to access that service. That's the assumption, in order for it to become comprehensive. So when you were listening to Dr. Dzokoto, he was talking about the fact that the NHIS coverage access is not the same as effective coverage, which means that there's certain inequity in distribution. So what we are looking for when we talk about comprehensive coverage is that it will be available equitably, irrespective of where you are. And that this equity is in terms of infrastructure, human resource, equipment distribution, and that there must be a quality in the care and of the care at all times. So it's not just anything. It must be at least meet the standards that are expected. Then in terms of finance, it is assumed that somebody will pay for it in one way or the other. Right? Either it's going to be paid through some kind of pooled funding mechanism, which we call health insurance or the social insurance programs, or through a taxation framework, which means the government puts it on its budget and pays for it. Otherwise, it comes out of your pocket, which means that you have to cough up that money. Or if you are lucky enough, you have some private insurance through a corporate financing or yourself that can cover it. Next. So the question I was asked, which is an examination question, and I haven't seen the marking scheme, is that is comprehensive health financing attainable? If I say no, I'll be in trouble. If I say yes, I am still in trouble. So I'm going to just chance on one end and say, let the others deal with the no and let me deal with the yes. So generally, I would say yes. I mean, theoretically, it should be attainable and it should be sustainable in the long run. If you can find the money. That is the caveat. If you can find the money, anything is possible. So that is the bottom line at the end of the day. If I can find the money, I can build the systems, build the structures, and make it available for anybody at any time, everywhere. So the money must be in the bag. But one thing that we don't emphasize very much when it comes to that is that we assume that it's only about the purchasing and that the money must be available to buy the service. But is the service available? That is the question. Are the services available? And will it be available in the right quantities, in the right quality at all times and in all places, irrespective of who is asking for it? Again here, the assumption is that when we talk about sustainable health financing and comprehensive health care, we assume that it is the government that must produce it. And I guess that assumption is why that question comes up. Is it sustainable? It means, so the production and the purchase is all at government. If you look at it critically from that perspective, what you are saying is that government is buying its own services. Right? Which begs a question of efficiency, but I'll come to that. And begs a very fundamental question that is not debated enough in terms of financing healthcare and its investment. But I guess that's for another day. But let's just put it in our minds, the students, that anytime we are talking about this, remember that it's two sides. It is who is buying and who is investing. If no one is going to invest in it, then it is never going to be there for you to buy in the first place. And to make that attractive to get others into it is a critical part of comprehensive health care finance. So as clinicians, what is the role of the private sector? And are they willing to put that in, the investment in, for that to happen, in order to have it as comprehensive as possible? Anyone outside government looking to come into the health sector to invest will be looking for three things. Please pay attention. Because those three things are fundamental to whichever purchaser is engaged in the system. Okay? And whichever investor wants to get in. The first one is the demand going to be there? Whichever service you put in, whether it's specialized, it is primary, whichever way it is, will the demand be there? The second one is, would the revenue stream be consistent in order for us to have it sustainable? So if I'm investing, will the revenue stream be consistent for me to recoup the investment and also retain the infrastructure, the equipment, and the human resource, and all the productive factors in a consistent way? The absence of that is what introduces poor quality. So if I cannot have a consistent revenue at the right pricing year on year, then there's a problem. We cannot have a sustainable company. And the last part is, will my risk be mitigated? Which means that will government policy change in the middle of when I have just started putting in investment? In terms of the finance, in terms of the revenue, in terms of infrastructure, in terms of who gets what, the benefit package, all of that. Will the government policy be consistent, or will it change in the middle? And what will be the exchange rate issues that will come to by itself. So these are fundamental when you are thinking about sustainable, comprehensive health finance. Okay? Now, when it comes to the, I've spoken about the private sector being one of the investors that we don't talk about get there. So that we need to create a certain space for them to sit in. But that space doesn't seem to be very clear in many countries. So that wherever they are giving a leverage into that space, government kind of creeps into it through another door. And we need to look at that carefully in order to get it stabilized. Then we talk about the government itself and the allocations that it puts in. And Abuja has been bandied several times around that we need a 15% in, and others have never achieved it. I don't know even if the developed world does that. I'll come to that in one slide and finish it. It really is a question of not the proportion, but the quantum. If a country's GDP is 100 cedis, it's not the same as a country's GDP, 1,000 cedis, and you are taking 15%. 15% of 100 cedis is 15 cedis. And 15% of 1,000 cedis is 1/5. So what you need is for the economy itself to be on a trajectory of growth in a sustainable manner for it to have the resources to deal with that. If that doesn't happen, then it's a problem. Now, the GDP itself is kind of struggling with a number of things. Of course, we all know that medical inflation is higher than even consumer inflation. And in this country, and many of the low middle income countries, this is quite a problem. And Ghana probably has the highest in the region. Know that. That our medical inflation is very high. The amount at which we buy medicines and equipment is way higher than most countries. And it's something that countries that are looking for comprehensive health financing need to look at. Give me the last slide and I'll say it so that we can have the rest of the panel. Next one. So, are there any countries that have achieved? The assumption is that if we hit 90% of effective coverage, we have achieved comprehensive healthcare finance. A few countries have done it in the East. Germany, France, we know about Singapore, South Korea, have done it. They have a coverage of almost 90%. There are issues, but generally it works. But if you look at their GDP, health expenditure, between 9 to 12%. Reason is simple. They have the deep pocket, bigger. So don't need that proportional allocation. So sometimes I prefer to talk about the per capita expenditure more than that. But we can look. Then in terms of the public share of financing, it's quite high. Because they run the welfare states framework. So it's generally quite high. If I brought America, you see it a bit different. Out-of-pocket expenditure, they still have some, but it's slightly deep. But if you compare that to the others, problem. But one big problem that we will come to when we discuss again is the issue of efficiency. And I hear by WHO colleague mentioned that a few times, and I've heard others mention it. Also, Chair, you mentioned the issue of efficiency leakages is highest in the LMIC. In fact, every resource we put in, we are losing almost about 40% to either corruption, poor purchasing frameworks, transactional costs, multiple lanes and channels. And this act working against us achieving comprehension.
Thank you very much. Dr. Sedo, what a way to end. Anyway, that was a very erudite presentation, and it makes me look forward to the panel discussion that we are going to be having. Let me just say that for our virtual participants, the chat box is activated, so you can start asking your questions within the chat box. Before I bring on the next speaker, let me just recognize the representatives from the Nursing and Midwifery Council. I have Dr. Lydia Janiselbi and Mrs. Inkum. Can we see you, please? Right, thank you very much. You know, our nurses, they carry us in whatever we do. We as doctors, we go and write things and leave, and then they have to bear the brunt of whatever it is that we do. For my nurses that I work with, they are like a firewall between patients and us, and they are able to act as shock absorbers, collecting all the problems that are aimed towards us. So we are very grateful for you, and you are a very big part of this discussion, because invariably too, they end up being the social workers, and they interface directly with the patients and patient caregivers and relatives. So it's important that we make them a big part of this conversation. And we are hoping that we'll have some contributions from you when we start the panel discussions and then the Q&A session. So our next speaker is a clinician. And I'm happy to ask to come upstage Professor Vicent Boima. And there's a lot I can say about him. All I can say is that do not let his height deceive you. He is coming to speak from the clinician's perspective, what we see as the problems with healthcare finances. So Vicent, over to you.
Thank you very much. As you can see, I'm short, so I'll leave you very soon. So I've heard from the economist, is this sustainable? He seems to say by default, he's leaning towards sustainability. And I've heard from Dr. Ernest as well, says that it's a reality. Mr. Chair, please allow me to stand on the existing protocols. Thank you very much because of lack of time. So what is the reality on the ground? Is it sustainable? Is it really, it's a mirage? Or it's a reality? The basic truth is, in Ghana today, when you fall sick, you still pay a lot of money from your own pocket, even if you have NHIS card. And I'm sure everybody here knows that truth. Even the policymakers who say it's a reality knows that truth. The government, of course, the NHIS, they pay part of it. Families still carry a heavy load, especially poorest families are the most hit when it comes to bearing the cost of healthcare in this country. NHIS card, what does it really mean? What people expect and what we see really. The NHIS card created so that at least cash and carry would be totally or partially or somehow weeded out. But people still pay a lot of bills, even in hospital for various reasons. In reality, many people with a card are still asked to pay some money for folders, for tests, for medicines, and even some procedures in our hospital settings. Because of this, some Ghanaians no longer even trust the card. Others don't even renew at all, but they feel that they still go and they pay anyway. And maybe it's because the healthcare cost is going up, perhaps the tariffs are not commensurate, but now that we've heard the tariffs have increased by 120%, hopefully we are on the road to reality, but maybe not there. So there is still some payment. Many facilities now quietly add top-ups, and we know it's happening. Because NHIS monies that come are too small, the tariffs are low, but as we just heard it's been increased by 120%, so I'm sure the facilities will be smiling. This means that you can walk into a facility with an NHIS card and still be told, oh, the money, the drug perhaps is not covered by NHIS, so go and buy. and they still go and pay for it. Or perhaps what you have to top up before you can buy it and all that. The test is different. The test is not covered by NHIS. These are some of the things, and therefore go and do it somewhere else. And they go and pay for it. So officially, NHIS says, these things, we don't want it. It shouldn't exist. And if you actually set a task force against this, all right. But it's still happening. And I'm sure they know that it's still happening. And I'll give you a few examples of what really these patients go through and what we experience with them. So hypertension, for instance, we know amlodipine 5 milligrams, they used to pay, these are estimates. So if NHIS will get me wrong, don't get angry. It used to be estimated cost for amlodipine 5 milligrams, for instance, used to be 3 to 5 Ghana cedis and reimbursement by NHIS. But the real cost in the market then was about 13 to 18 Ghana cedis. That means a top up of 10 to 15 Ghana cedis. So that's it. And then if you take, say, Pendro, thiazide diuretics, the NHI reimburses 2 to 3 Ghana cedis. The real market value is about 10 to 15 Ghana cedis, so top up of 8 to 12 Ghana cedis. That's just an example. I have so many examples. I'm going to skip and go to, say, somebody who has diabetes and hypertension, 2 diseases, for instance. The reimbursement for amlodipine plus metformin combo is about 10 to 15 from NHIS. But the real market value is about 40 to 50 plus. So a top up of almost 25 to 40. And you know some of these people have 3 or more comorbidities. Diabetes, hypertension, maybe asthma, etc. And they have to buy drugs for all this. So you can imagine how much they have to pay at the end of the day. So NHIS money then becomes a fraction of really what they pay in hospital. So for instance, if you take the new drugs that we use for protection of kidney, if you detect kidney disease early or heart disease early, the X-Forge, the Triplexam, the total cost per month is almost 500 to 600 Ghana cedis per month. And therefore, if you want to use these drugs to the benefit of the patient, it comes from their pocket, and they pay a lot. So what does that feel like for the ordinary family? One serious illness can wipe the whole family savings. That's what this means. The households end up spending a big chunk of their monthly income on health, especially the poorest families. When there is no money, people delay going to the hospital. We know that. They won't go. We call them and say, oh, doctor, I have no money to come to the hospital. They cut the tablets into halves because they want to prolong how long they take it. But it may not control the BP, it may not control the blood pressure, etc. They skip reviews. And therefore, we don't know whether their BPs, the things that we want to control to prevent end organ damage are being controlled or not. And someone that just depend on painkillers or some kind of drugs, or maybe they resort to herbal medication, etc., which further kills their organs. Parents quietly make hard choices. Do we pay for fees and monthly rent, or we should pay for that test that Dr. Ofreji requested for, or the drug that he prescribed? They have to make a hard choice. Perhaps pay for fees, perhaps pay for rent, and then decide to forget about the drug that they need for their own help. So the medicine, the drugs, and the labs are where people feel the cost the most. Even when the consultation is free, the bill comes from the pharmacy and the lab, etc. I'll give you an example from my own field. Dialysis, free dialysis, as they said last year. But who pays for the erythropoietin? Who pays for the catheter they need to do the dialysis? So as my colleagues are here, people are lying on the wall, they can't pay for the catheter, even though they can get free dialysis. That's an example. When there's no money, when the hospitals run out of NHIS covered drugs, reagents, patients have to simply be told, go and buy and bring it at a full cost. Transport to facilities, buying food while at hospital, losing time at work while at the hospital are all costs to the patient, especially the rural and poor families. People travel from far and near to come for review. People from as far as Wa, people come to our clinics. And that's what patients go through. So household studies show that the poorest families spend a bigger share of their monthly income on healthcare. For some, just one hospital admission or pregnancy can push the family into debt. Selling the land, giving up other basic needs like good food, children's education, etc., just to pay for health is what they go through. Over the years, a number of households are ruined by health bills that's really wiped away their family or monthly income. So through cash and carry pays, and then other health problems which really cause them to come to this point. So the health sector does not really have enough money, and therefore maybe that's the reason why patients are going through all these troubles. NHS struggles, but hopefully there's some light at the end of the tunnel. We've heard a lot about tariffs going up 120%. We heard about a lot about GMTF, Ghana Medical Trust Fund as well. So perhaps there's some light at the end of the tunnel. But is this a mirage? Is it reality? I would say perhaps we are on the road. Because even in this room alone, there are a lot of experts with the knowledge, with the understanding of what is supposed to be done. And together with all the other policy measures and GMTF, NHIS, hopefully we are on the road. But I wouldn't say it's a reality yet. Thank you.
Thank you very much, Prof. Boima. Prof. Boima paints a very grim picture. And the truth of the matter is, that's what it is. Where I work in Kolebu in the medical intensive care unit, daily we see people who need intensive care, but they simply cannot afford. And intensive care is not covered, unfortunately, by the National Health Insurance Scheme. So you have a big problem where people actually need services that sometimes are available, but they simply cannot afford. And therefore, we are not able to give them the care that they require. So indeed, these are real issues that he's been able to expound to us. And I think that it makes it a perfect timing because we are talking about chronic illnesses, complications of diabetes, hypertension, and the likes that are not met when it comes to financing. And therefore, we are all excited when we hear about the Ghana Medical Trust Fund. And I think that it is perfect timing for us to bring them onto the stage to tell us what it is, their role when it comes to healthcare finance. So with a round of applause, please welcome Dr. Norbert Kipo, who is the policy analyst for the Ghana Medical Trust Fund. And as I've said, he will give us a thumbnail introduction of himself before he does his 10 minutes. 10 minutes.
Thank you very much. Good evening to you all. Good evening to you all. It's a privilege to be here to the Ghana Medical Trust Fund and Mr. Chairperson permit me to continue on existing. When you have a session like this and you have a speak before you, it makes the work easy. So I'd like to just use this opportunity to talk briefly on what the Ghana Medical Trust Fund is about and talking sustainable finance. Probably when we have the panel discussion, we can talk a bit more on that. The Ghana Medical Trust Fund was established earlier this year in July, mainly to mobilize resources for the provision of specialized medical care for persons living with chronic, non-communicable. It comes at a time where we have to throw light on a particular focus. The National Health Insurance is covering a lot of conditions. But then we have a challenge on a few decades ago. The focus was on communicable HIV, malaria, and rightly so. But at a time like this where the dynamics have changed, where we have about 45% of all age mortality being attributed to the non-communicable diseases, then the focus also has to shift. So the Ghana Medical Trust Fund is government's commitment supporting patients who go through the catastrophic cost, who go through the high financial burden of having to pay for their medical cost when it comes to chronic non-communicable disease. Aside the mortality burden, we all appreciate that a lot of individuals, when they are diagnosed of non-communicable diseases, not just the individuals, but the entire family, has to go through a lot of financial challenge. And research has shown that about 75% of households, not just the individual, fall below poverty lines within the first 5 years of a diagnosis. We also admit that in our health systems, not only human resource, but in terms of equipment and infrastructure, there's a huge deficit. It's not just the speaker on health economics made us understand that it's not just about the affordability. Even if there's someone to pay for it, the big question is it accessible? So if, for instance, it becomes free to do radiation therapy, the person from Tumu who has the breast cancer, can she access that service in her region? Or maybe the next region, or she has to come all the way to Accra to have radiation therapy. So while we look at the affordability of it, it's also important to consider how accessible healthcare is. And this is where the Ghana Medical Trust Fund comes in. Our main objective is to mobilize resources to support specialized medical care for chronic non-communicable diseases. Emphasis on specialized medical care because we have the other layers of protection in the medical or in the health setting. We've had the NHIA that has been with us for over 2 decades, and we have introduced the free primary healthcare policy now, which should take care of prevention of disease and health promotion. The other layer is the National Health Insurance Scheme, which covers for most conditions. Then the Ghana Medical Trust Fund sort of sits at the top of the pyramid. So once individuals go through all the stages and you get to a point where there is no longer coverage from the National Health Insurance, then the Ghana Medical Trust Fund can come in. Our objectives are broken down into these 4 pillars. The first one has to do with the direct patient support, which is the very popular one that a lot of us know about, where the fund seeks to make it affordable, seeks to pay the bills for patients who have some of these chronic non-communicable diseases. Secondly, we are looking at capacity building. Once you have to provide specialized medical care, you need specialist doctors, you need nurses, you need pharmacists, you need your biomedical engineers and technicians to be able to care for your complex equipment. And as part of our mandate, we want to support the training of these specialists to be able to offer the specialized medical care to our patients. Again, I spoke about infrastructure and equipment, and as part of our mandate, there's this part of the mandate that has to do with supporting facilities with infrastructure and equipment in respect to their bid to provide specialized medical care for patients with chronic non-communicable disease. And finally, we are supporting medical research. Research and data is very important to be able to shape policy, to be able to shape our interventions, and any research that is geared towards giving us more data, giving us more information about our disease patterns as far as non-communicable disease is concerned is very much appreciated, and the fund will support such research so that we have this data and information available to be able to shape our policies and our interventions. The fund has a governance structure which is made up of a 13 board of trustees, of members from various fields, medical field, pharmaceutical, legal, health economics, representation from government, and it's a very structured board of trustees. Established with Legal Status Act 1144, which, like I mentioned, was assented to in July 2025. So it has legal status. It's a body corporate that can acquire property, engage in contracts, and we have an administrative structure which is made of a secretariat that runs the day-to-day activities of the Ghana Medical Trust Fund. So this is just the composition of the Board of Trustees, which I spoke about. So the elephant in the room, the funding of the Ghana Medical Trust Fund. When you talk about making it affordable, like Dr. Sedo said, someone has to pay for it. Even if it's free, someone has to pay for it from some means or the other. So for a start, the government is allocating 20% of the National Health Insurance Levy for the Ghana Medical Trust Fund. And this comes on the back of the fact that the NHIL has now been uncapped, and that has made available some over 3 billion Ghana cedis. And we are hoping that that 20% of the NHIL, which would directly or indirectly come from the uncapped portion, would move to the Ghana Medical Trust Fund for it to be able to achieve its mandate. Aside that, there is also the responsibility of raising monies from corporate societies, from civil societies. We also have the mandate to invest some of these monies to be able to raise funding, not necessarily from government, 20% allocation of the NHI to be able to support some of these. We also receive grants and donations. However unsustainable this may seem, but this is a start. And I'm glad that we have a forum like this where we can discuss and explore other avenues where we can provide funding, not necessarily from the 20% allocation of the NHIL. When it comes to the disbursement formula, some factors are taken into consideration. The first has to do with the disease burden. Here we are looking at the cost of care, what is cost effective, and these would determine how we allocate the monies available. Secondly, and very important, is the geographical equity. Because while you are making it affordable, again, equity and access is also important, so that patients, as we sit in Ghana, to be very honest, when it comes to human resource equipment, it's mainly Accra, Kumasi, and maybe Tamale. But elsewhere, it's a challenge. So we have to look at how we can upgrade our facilities, or we put our facilities in a state where individuals do not necessarily have to come to Accra, do not necessarily have to travel 100 kilometers for a dialysis session, do not necessarily have to travel to Kumasi to be able to have an MRI imaging done. This geographical equity also influences the disbursement of funds. And finally, the health outcomes. This is where data and research is important. We are looking at the disability, the disease burden in terms of morbidity. We are looking at the mortality. And this will help us, first of all, even determine the benefits package. The Ghana Medical Trust Fund focuses on non-communicable diseases, but we all understand that that's a wide range of conditions. And for a fund that is so young, that even has to have discussions on sustainable funding. Putting all these conditions on the fund all at once risk collapsing the fund even before it takes off. So we would consider the disease burden to be able to determine at least which conditions we can start with, and with time, as we explore other sources of funding, then we can expand to cover more conditions. Who stands to benefit from the fund? First of all of us stand to benefit, directly or indirectly. One way or the other, we are all deeply connected to non-communicable diseases. If not you specifically, but you have a relative. You may have a relative who has an NCD, you may have a colleague at work, you have a friend who may have an NCD. And once they benefit from the fund indirectly, you also stand to benefit. Our health facilities may benefit from some investments in infrastructure and equipment. But the Ghanaians who would directly benefit from the financial support for the conditions, of course, first you have to be Ghanaian. We recognize that there are non-Ghanaians in the country who pay taxes, who sort of contribute to the data when we are looking at the morbidity and mortality. But then, like I said, for a fund that is young, we have to be careful about how we roll out the implementation of the program. So we may have to put in some exclusion criteria at the beginning, and whilst we grow, then we expand the coverage. The NHI, as we have it today, was not the same way 22 years ago, but over the time, they have added on conditions, have expanded, and this is something we hope to do. But for a start, this is a policy for Ghanaians. And secondly, you should be registered on the National Health Insurance Scheme. This is particularly important because we want patients to go through all the layers of health protection in the country. Because for a patient to be diagnosed of a condition that will require catastrophic expenses, we hope that you should have gone through the systems, from the primary health care to the National Health Insurance, and at a point that there is no longer coverage for you, then a Ghana Medical Trust Fund can come in. So this is proof that individuals should have gone through the system, and this is also a way of helping us keep our data. And of course, you should have a condition that is covered for under the Ghana Medical Trust Fund. This is the application process. So we want patients not to apply directly, but to apply through they are specialists, because this is specialized care. So your specialist who does the consultation puts in an application on your behalf. This is very important because it helps us also do away with fraud, so that patients do not just sit at home and submit applications when they do not have the conditions. Also, getting an application from a specialist is also some proof that you are going to get specialized care because you are seeing a specialist. So the application is made on your behalf, the fund reviews it, and a decision is communicated. A decision as to whether you qualify or you do not qualify, you have to be communicated to. The hospital goes ahead to offer the service, and reimbursements are made based on the benefits package and the tariffs. However, there are some caveats to this. For example, there are some conditions that will require interventions that are time specific. For example, in strokes, where you have just a short window to be able to make a meaningful intervention to prevent permanent disability. Or in myocardial infarctions, where you have a very narrow window to make interventions. We are making some caveat for those emergencies where treatment can take place and then a review would be done later, rather than having to submit an application and wait for maybe 2 or 3 days to get a response, and by that time you may not be able to make any meaningful intervention. So for the benefits package, this would be determined by the Board of Trustees, of course, with recommendations from the Technical Oversight Committee. Whatever benefits package will be determined will be communicated transparently to all stakeholders, Ghanaians, patients, medical professionals, hospital managers, and also there will be a continuous evaluation year in, year out. This will allow for some conditions to be added. This will allow for the benefits package to be adjusted to reflect the true state of the economy and the actual cost of care. To maintain quality, we'll be working with some regulatory bodies. HEFRA, for example, would assist in credentialing health facilities that would be on the Ghana Medical Trust Fund. At this point, I want to add that not all hospitals will be engaged on this policy. This is because we are offering specialized medical care. So obviously, primary facilities that do not have the capacity, either in terms of human resource or equipment, it would not be prudent to work with such persons if the patient goes there and doesn't have access to, say, a physician specialist or a nephrologist or a dialysis center. It's just not right for such a facility to be offering specialized medical care for kidney disease. So HEFRA would help in that credentialing of the health facilities. They are expected to display their certificate for patients to know that this is a facility where I can come in and I can have some financial protection from Ghana Medical Trust Fund. We'll also be working with other regulatory institutions like the Ghana Medical Trust Fund, the Pharmacy Council, Nursing and Midwifery Council, to make sure that the specialists we are working with are actually specialists and they have met all the requirements to be able to practice in the country. We would have a medicines list, just as we would have a service list. The medicines list would classify medications, regroup, add medications as and when, but that will be an annual review. There will be some special instances where new technologies can be approved by the board. A classical example was when we had COVID and we had to introduce some vaccines. So when you have certain peculiar conditions like that, where you need to adopt new technology, the board will give approval for us to add such medication to the medicines list. For the payment mechanisms, we will be doing the fee for service, like the National Health Insurance, where there will be some itemized billing based on the medications used, and there would also be the diagnosis-related payments. But we also consider other mechanisms that we believe would work for the scheme. For claim submission, it's as simple as you have it there. Service is delivered, the facility submits claims, they are vetted, reimbursements are made. The event that for some reason the claims are rejected, the facility has the opportunity to correct whatever mistake it is, if it's clerical or just something that can be worked on. But of course, if it's on the basis of fraud, that will not be allowed. But if it's clerical or some mistake, the hospital is allowed to work on that and submit it for reimbursement. So in the nutshell, this is the basic thing about the Ghana Medical Trust Fund. I mean, our bill talks about so many things, but for the purpose of this discussion, I'll just leave it open up for us to be able to have discussions on sustainable funding for the Ghana Medical Trust Fund. This is supposed to take care of catastrophic costs. So that would mean that we need a lot of money to be able to take care of the cost. For example, when it comes to cancers, and you have to pay for surgeries and maybe pay for chemotherapy and radiation therapy. For one patient, the average cost for managing the non-communicable disease is about 56 Ghana cedis. So if we have to do that for over 4,000 patients with cancer, then you can imagine the cost implications. So we are very excited about such a forum like this, and we can explore ways by which bring sustainable funding to make sure that the Ghana Medical Trust Fund, which is here to protect Ghanaians from the catastrophic medical expenses, is actually a reality, and we all stand to benefit from it. Thank you very much.
Thank you very much, Norbert. I'm glad that Norbert has demystified what Mahama Cares is all about. And we understand that it's still very much in its infancy, but we are very hopeful that it will be able to meet the need that it seeks to address. So we are gradually inching close to our list of speakers that we have put together. And so far, we have heard from, governments, economists. I think it is time that we heard from the private sector as well. So kindly join me, welcome Mr. Ronald Adom, who is the acting president of the Private Health Insurance Association. He will be delivering a topic on the role of the private sector and innovations. So please welcome him with a much bigger round of applause. So, Ronald.
Good evening, everyone. And Mr. Chair, I wish to equally ask to stand on the existing protocols. I don't have a doctor attached to my name. I didn't want GTech to come after me, so I didn't have one. So, as has been introduced, I am Ronald Adom, and the acting president of the Private Health Insurance Association, which is the official trade body for private health insurance in Ghana. And I'm also the managing director for Star Health Insurance, one of the licensed private health insurance companies that we have in Ghana. So I'm to speak briefly about the role of private health insurance and also the innovations in the space. When I looked at the topics for the other speakers, I was wondering why is it that it's only the private sector that was asked to speak about innovation, but it's understandable. Yes. So private health insurance in Ghana, it's a little over 2 decades, because before the official passing of the Health Insurance Act, private health insurance was very prevalent in Ghana, especially in the formal sector. And as we speak currently, there are 17 licensed private health insurance companies in Ghana, and they provide coverage to almost about 500,000 persons that we have in the country. And the coverage that is provided focuses on curative care, preventive care, and when it comes to preventive care, as much as 40% of our insured population annually get the opportunity to screen once every year. And then also, a lot of our care is also, some bit of it is focused on palliative and rehabilitation care. For instance, in 2024, private health insurance made a total contribution of about 830 million cedis in the payment of claims, which translates to about 5% of the total healthcare spend for the period. Over the years, what private health insurance has been doing by way of the regulatory framework is to complement, supplement, and duplicate the NHIs, because that's the ambit within which we are to operate in Ghana's quest to achieve universal health coverage. And so to be able to also achieve our goal, private health insurance has specialized in the reducing healthcare financing barrier, especially in the formal sector. I like the point Dr. Sedo made earlier, that if you are asking for an investment to be made, we need to be able to answer the 3 fundamental questions that he did ask. There's a lot of talk about Private health insurance is not growing in Ghana. It's only limited to just a few people in Ghana. The issue that must be asked largely is that, are Ghanaians prepared to pay for the cost of the care? Because a private insurer would invest into setting up the business, and regulation requires that we operate within a certain context where your capital adequacy ratio is above a certain level. And so if you spread yourself too thin, you will fail the regulation and your business will not be sustainable and your license will be revoked. And so all of these are put together to ensure that private health insurance that run sustainably. And so to deepen the reach and make access for many Ghanaians possible, private health insurance leverages technology. We are aware of telemedicine, where a lot of our members, irrespective of where they are in Ghana, can get onto the phone and speak to a practitioner and get some advice in that direction. Also, we provide coverage through our chronic management programs to moderate the incidence of NCDs. And again, by way of technology, a couple of years back, we introduced the electronic claiming to reduce the claim payment turnaround time and ensure smooth access to healthcare. So looking ahead, as we make healthcare accessible to all residents in Ghana, we look forward to partnering the college to moderate the cost of specialist healthcare costs. Now, when we go to tariff negotiations, one of the key things we are told always is that the specialists are making things difficult for the facilities. And so their cost is rising and facilities are pushing the cost over. We at the private health insurance space believe that, like it's done in other jurisdictions like South Africa, the time has come for us to be able to have a certain kind of tariff agreement with the specialists themselves, so that irrespective of where you go and practice, your tariff is predetermined. Because at the moment, it seems to be that we are flying in the dark, and we are told that specialists are making the cost of consultations very difficult. And so we look forward to partnering the college and to ensure that that is equally addressed. Secondly, we also look forward by way of contribution to a review of the legal framework within which health insurance or private health insurance is set. We believe that for private health insurance to thrive by way of extending coverage to a lot more Ghanaians, there needs to be a review of a sort by making private health insurance compulsory for certain segments of the population. For example, those in the formal sector and non-resident Ghanaians at the least. We believe that is a key thing that must happen. And lastly but not the least, healthcare cost keeps rising. And for private health insurance, which do not have any governmental support by way of tax relief and other contributions from the National Health Insurance Fund, the only remedy available to us is the premiums that we charge. And so premiums would be charged to be able to meet the rising healthcare costs. But we believe that one way to redress rising healthcare costs, just like NHIS has done through its tariff that it intends to increase by as much as 120%, we believe that as a regulator, the regulator should equally also take interest in ensuring that tariffs in the private space is equally moderated and regulated to an extent. Because if this is done, then the cost of buying private health insurance can equally be controlled, and a lot more people would be able to afford it. And so we look forward to an interesting discussion during the panel discussion. Thank you very much for your audience.
Thank you very much, Ronald. Ronald has thrown some shots as specialists. but we'll take it in good faith. We need to sit down with them and understand what they mean by they are frustrating the process. But it's all good. That's why we are here. We are here to learn, understand what the problems are, and find solutions for them. So finally, we come to our last speaker. And when he comes up here, he needs to explain to us why a deputy commissioner of the GRA is dabbling in healthcare. And I'm sure that once he introduces himself, he'll be able to explain to us what he does and how he's firmly into healthcare and why he's speaking at this particular forum. So with a round of applause, please let us welcome Dr. Combat. As I said, but let me let him do his own introduction.
Mr. Chairman or Prof. Chairman, distinguished professors, and other top officials, ladies and gentlemen, I'm Alex Combat. I'm the Assistant Commissioner in charge of tax policy and research. Actually, my PhD study was in health taxes, environmental taxes. That is why I'm so passionate and interested in taxes, health issues. And I've actually helped champion a lot of the health taxes in GRA. And so currently we have a few of the health taxes, which I think are very helpful for healthcare. So it's my slide on it. Just I was asked to speak on equity, accountability, and citizen perspective. So please, you can go on. So just a background. I have just 10 minutes. Is it okay? Actually, I got this graph from Institute for Health Metrics and Evaluation. It's an online portal that actually analyzes health issues. And here, they decided to rank deaths by risk factor in Ghana. And you could see that high blood pressure was the highest, followed by air pollution in that order. So this graph actually exhibits that. Can I go on? All right. Can I have the next slide? Actually, the next slide talks about health expenditure per capita. And health expenditure per capita, the WHO recommended amount is 86. And for Ghana, it was 52.5 in 2018, and then it rose to 98.9 in 2020, and then 96.2 2021, and then came down to 83.4. That was 2022. Okay, you can go to the next slide. Don't have to waste time here because most of the speakers talked about this slide. So the slide has a nice bulb, and then the bulb has about 8 sources of healthcare funding sources. Of course, we may have more than this, but just to mention a few of them. So the National Health Insurance Scheme, government tax revenue, and petroleum. And then we're talking about the general budget and annual budget funding amount, or pocket payments, private health insurance, donor funding. We just had a speaker on the Ghana Medical Trust Fund, provider tariffs, and then public-private. You can go to the next slide. Now, allocations to the health sector. So Ghana increased the National Health Insurance Scheme allocation in the national budget from 5.9 billion in 2024 to 9.8 billion in 2025. That was 66% increase. And then we have the health sector being allocated 34 billion, representing 9.4% increase over 2023 budget. And in about 11% of total government expenditure. And the National Health Insurance Scheme alone had about 11.2 billion. And then the National Health Insurance Levy, we are talking about what we collect. It yielded 347,110.10 million Ghana cedis in 2024. That was about 35% increase. And then we also, COVID was just cancelled. But before that, we had about 2.9 billion from the COVID. So let's say close to 3 billion. And then we have PRA imposes taxes, products that are deemed harmful. These are called the health taxes. And that also generated about 2.2 billion in 2024. The Ghana Medical Trust Fund, the 2026 budget actually allocated 2.2 billion for this particular fund. And the problem got to do with equity. And for equity, what we realized was that healthcare has always been centered on the communicable disease, not much on the NC. So we are extremely excited. The president has actually come up with a fund which is making the NCDs popular. But in terms of the healthcare quality, the NCDs were not actual. And there's an even distribution of health workers across the length and breadth of the country. That is operating. And then we also have inequalities in terms of infrastructure. And we also have a lot of problems related to the economic barrier. Transparency and accountability. So we have laws and legislative oversight. So the GRA Act outlines how we should collect the taxes, how they should be paid into the consolidated fund. Internal audits, external audits, and application of technology, political economy of the healthcare sector, and data and voices on healthcare, and parliament oversight. So we are recommending that the COVID-19 levy that was just cancelled, if it can be reintroduced, and then the name changed. We only need to change the name, and then we can channel the funds to healthcare. And then if we can also earmark health taxes for medical trust fund, that will also. Then awareness creation, equitable in the distribution infrastructure, talking about health personnel, completion of healthcare infrastructure, and multi-sectorial collaboration. So that is it. Talking about reliable sources of healthcare funding, which are very important. And We are also talking about the fact that we need equality, healthcare, delivery, and we are just saying that healthy population economy. Thank you.
Thank you very much, Doc, and explaining the mystery behind your love for medicine. We've come to the end of the speeches by our distinguished panelists. I think that this has been very wonderful, and we've had very good exposés from government to NHIS to Dr. Boima, Prof. Boima telling us the reality on the ground from the clinician's perspective. So it is time that we move to the next section, which is the panel discussion, which promises to be very interesting. So at this juncture, I'd like to invite all our speakers to sit up here with me in no particular order. And I promise the questions are also not going to come in any particular order, but they will be very provocative and sometimes intrusive. But please come up stage and pick up your seats. And the chat box has been open, and therefore our online participants can put questions in the chat box. Yes, Dr. Sedo. Good, everybody. Good, let me separate myself from them so I can ask my questions well, whilst they greet themselves. So, Dr. Combat, it's not because you are at the far end, but you said something very interesting, which is reintroduction of the COVID-19 levy. Give it another name, you said. What do you, I mean, I know you did say it, but number one, it's going to be a very controversial recommendation that you've made, considering that it was once considered a nuisance tax or a tax that had outlived its usefulness. But can you just briefly give us a justification? I know you did mention it, but if you could go a little bit more into why you think that that reintroduction is necessary, considering the other things that NHIS is doing and the Ghana Medical Trust Fund is also looking at doing.
Okay, thank you very much. So it appears all the speakers actually alluded to the fact that we have funding gap when it comes to healthcare. And so, especially when the official from the Ghana Medical Trust Fund, I mean, you could hear from him that the fund actually needs a lot of money. And we were thinking that the COVID-19 levy was introduced in 2021. And averagely, we were collecting the tax, and averagely we were earning close to, let's say, about 3 billion every year from the COVID-19 levy. So we were thinking that just scrapping it and let the 3 billion, go just like that, we could have channeled it to other healthcare funds to support healthcare. So that is our reason.
Right.
So it's a matter of just changing the name, and currently we have acceptability of the tax. The only problem was that people felt COVID-19 was no more, and why should we be collecting tax on COVID-19? But if we had changed the name and then just said, okay, we are raising these funds to support maybe even the Ghana Medical Trust Fund, that would have been excellent. And I know people would have accepted it because we know the dangers of the NCDs. And until recently, and I really applaud the president for having this in mind to tackle the NCDs. They're actually killing a lot of people. And if we had a fund like this, the Ghana Medical Trust Fund, and we could have a reliable source, because if we listen to the official from the fund, he said it is 20% of the National Health Insurance Levy. Is that not it? Yes, so this is like you are just parasiting somebody's fund. You see, the National Health Insurance Levy was basically for National Health Insurance Scheme. Now we had to parasite it, take 20% of that. But we could have just said, COVID-19, don't go. The 1% should be channeled to the Ghana Medical Trust Fund, and it would have worked perfectly, and people would have accepted it. Thank you.
Thank you very much, Dr. Combat. So, Doctors Dzokoto and Kipo, what's your response to this? Is this something that you would subscribe to?
Thank you very much. See, Dr. Kipo handed over the mic to me. It looks like a landmine. Thank you very much. Obviously, there's a gap in health financing within this country. And we all agree that we need to be able to use more innovative ways to raise more funding. I've heard this debate on the COVID-19 levy. The fact, we all saw the devastating effect of COVID-19, what it did to our economy. And you could see what happened in 2021, 2022. It affected almost everything, including employment for the people of this republic. And it was a global, it was a pandemic, obviously, so it was a global challenge, right? So do we wait for the next pandemic before we say we are preparing again to deal with it? So there's a public health emergency preparedness that we have to begin to look at. So it's a very good advocacy. We really need funding for so many things, including public health emergency. So if you are able to explain it to the people of this republic, that yes, it was for COVID-19, we saw the effects, but going forward, the next pandemic is just a few years away. We need to prepare. I think WHO has been very supportive when it comes to preparedness for such public health emergencies. But we as a country, what are we doing to make sure that we don't get to the situation where we were in when COVID-19 came in? We basically didn't have any ICUs for infectious diseases. We had to hurriedly get ICU beds across the country. Our oxygen capacity was not very good. Our surveillance capacity had to be enhanced within a very short period. As of now, even as I speak, most regions don't have emergency operating centers. I think we have it in just about 6 or so. We recently also got a national EOC. So there's so much that has to be done when it even comes to public health emergencies. And I think the COVID-19 levy is something.
So in essence, you support it?
Yes, in the context that I just put it, I support it.
Okay. Dr. Kipo.
Thank you very much.
It is said that they've robbed money from him to give to you. So is this something that you would support? Or is this something that you would recommend be looked at?
So like Dr. Dzokoto said, there is a funding gap. And for the Ghana Medical Trust Fund, I believe it's important that it has a reliable stream of income. At the moment, taking 20% from the National Health Insurance Levy seems reliable because it's something that is guaranteed year in, year out. As long as NHIL is collected, there's a 20% for you. But then, these were funds that were allocated to the NHIA because they had a mandate. And throughout this discussion, people have spoken about the fact that we may have to increase the NHIA coverage. So if NHIA had that full complement of their revenue, I'm sure they'll be able to do more. But then that leaves us with the question of what then is the reliable stream of income for the Ghana Medical Trust Fund. Converting the COVID-19 levy could have been an option, but I don't think that's the only option, because this was a levy that was imposed as at the time that there was a need. But then after a few years, many Ghanaians believe it had outlived its usefulness. Ghanaians and the business community labeled it as a nuisance tax. So politically, there was some pressure to take it off. Let's also situate all this health finance in the political context. There was some pressure to take it off. But like I mentioned, even though that could have been one of the streams of reliable income, I don't think that's the only option to consider. In the presentation from Dr. Combat, he did talk about the health taxes. This is taxes imposed on certain products which we believe are risk factors for some of these non-communicable diseases. Sugar-sweetened beverages, tobacco, alcohol, and the rest. This is also another place where we can channel. I mean, this is a tax that is already in existence. It's not about introducing a new tax. So then you take away the kickback from the public because nobody likes taxes, as a matter of fact. We all acknowledge that they are important, but nobody likes to pay more taxes. So this is a tax that is already in the system. So we can advocate that it's only fair that products...
It should be renamed, sort of.
Well, the health taxes are being collected, but then it goes into the bigger pool, and it could be used for any kind of expenditure, which includes health, but of course it could also be used for something else, roads and the rest. I believe that we can make a case that it's only fair that the products that we believe are risk factors, or broadly speaking, are the cause of some of these non-communicable diseases, it's only fair that those monies are put back in the solution for the problem that these conditions cause. So this is also another, in my opinion, this is also another way that we can look at a reliable stream of income for the Ghana Medical Trust Fund. For now, the COVID-19 levy is gone, and politically reinstating it would come with a lot of kickback that I don't think anyone is ready for. But we can explore the other options where health taxes, which are taken from products that are believed to cause some of these conditions, are put back in the grand scheme of events in attempt to get the solution for that. So I think that the COVID-19 levy was an option, but I think we have lost that opportunity now, and we can consider other options as it stands now because of the political reasons and the kickback that may come against it.
Okay. Dr. Sedo, do you have a comment on it?
Thank you very much. Any tax that is introduced has to be weighed against a number of factors. It has to be looked at whether it's either going to be progressive or it's going to be regressive. And to understand the impact on the general population in terms of equity, not just the mobilization. So I tend to agree with government taking COVID-19 levy out on those two principles. One, that when COVID-19 levy was introduced, it was not introduced with any discriminatory framework. It was not differential. Okay. So when the tax was introduced, it was not differential. It was a broad-based tax. So it incorporated in itself a regressive framework. It was on almost every good and every service. And that is problematic when you are introducing taxes. And as it were, over time, that becomes burdensome because it becomes layered on existing taxes, and there's no space to free the population that are suffering from that kind of framework. So I agree that it needs a total review by itself and not introduced on its current blanket base. So if we need a framework that generates a pandemic preparedness fund, we need to approach that in a very different way and put it on a base that does not make it regressive. That's the fundamental. So I tend to agree that COVID-19 needs to go, and let's rethink it.
Thank you very much, Dr. Dodo. Let me stay with you. And you know, the 2026 budget allocations, which is what announced the removal of the COVID-19 tax, do you think that the budget allocations that have been done in this recently read budget addresses the systemic sustainability issues that we have? Or do you see it as a short-term fix for deeper line issues that we are not addressing adequately? Am I asking difficult questions?
It is a difficult question. It's not a straightforward yes or no answer, but let me attempt. Any additional resource to the sector is a welcome news. because the glass is half full. I don't want to say it's half empty. Let's be optimistic. So the additional resources that is coming in is very, very encouraging. But we need to understand those resources in terms of budget and releases. And historically, we have seen a pattern where budgets are drawn, but the releases become truncated out of pragmatism, because the resources have to flow over a certain broad range of things. And anytime there's a strangulation, you need to plug in somewhere to deal with that. So that is true. The other thing that we need to understand also is that these additional resources that are coming in also needs to be applied in a very pragmatic way, understanding that it is released this year and whether we have that consistency in the years to come, and whether the economy will hold so that the real value is retained over time to deal with the things. And then we also need to understand those resource releases not as a windfall, because right now it's as if we've had money and we're treating it like a windfall and we want to spend it out. But there's no safety net behind it, so that we are not creating a sinking fund that protects us against the shocks going forward. So there are a number of things, but these are just a few of the things that I wish that a sit down can be had on the conversations. So I do understand that we're talking about because we're getting this money, we are also projecting expenditure, and we have reviewed the tariffs in that framework going forward. I know that it's a proposal that is going forward, but the implementation framework, I believe that my colleagues in the NHIS will look at that so that it does not just run across. But yes, that money is hopeful. We thank government, and I really, really applaud government for that brave approach to it, but there is some detail that needs to be worked out.
Okay, thank you very much. So, Dr. Dzokoto, I mean, obviously, you did say that the NHIS is increasing the tariff come 2026, alongside with the uncapping of the NHIS fund, which has been well welcomed by all parties on the table. My question to you, however, is that how are you going to ensure that these reforms actually reduce the out-of-pocket payments, especially for the most vulnerable people within our society?
Thank you very much. Our claims liability for 2025 was 3 billion cedis. And with this increase, we are looking at paying out over 6 billion cedis. And within the 6 billion cedis, we can confidently project that a modest estimate of 15% is due to leakages. So if you take 3 billion cedis, that means we are looking at about 450 million cedis that are being paid for undeserving claims. And that certainly is not efficient use of money. Number two, people have gotten used to the out-of-pocket payments, and engaging providers objectively, they let us know that for two reasons. First, because we were not paying claims on time, and because the tariffs were not realistic, they had to charge clients, although they had a contract with NHIS. So one major step that we had to take was to have these realistic tariffs, as you have said. But we are taking time. This should not be something that should be confrontational between us and providers. We understand the circumstances is due to a lot of factors, sometimes not within their control. So we've gone around the country. For the past 2 weeks, we've been engaging health leaders at the various regional levels. Across, tomorrow we are doing the last one in Central Region, explaining to them, taking our time and breaking down what the Ghana diagnostic-related groupings means. And this is being led by none other than Reverend Professor Adokwe Hesse. See, so one step is to let everybody understand what goes into it. Because it's very easy to say that on a case basis, Well, they say X-ray costs 75 cedis, but when I go outside and go and take an X-ray, it's 150 cedis. So I'm being shortchanged by the NHIS. But there's a way of calculating it. We average it times the number of patients that come to your facilities. Maybe out of 100, 50 would need X-ray, 50 would not need. So based on that, we calculate and give you a certain rate that will allow you to have margins. So now that we explained to them, we know that the tendency to feel that you are not getting enough would reduce. Then number two is realistic. The tariff is realistic. You are able to meet all your overhead expenditure as a hospital, so there's no need to actually charge. Then the three is to look at it in this way. We need to do everything to prevent it. So key advocacy. Today we were with the Vice President of the Republic, and she was emphatic. We have to make sure that we advocate when the people of this republic who are being asked to pay illegal payments are aware of what is illegal. When they go to facilities and they ask them to pay, they are not going to pay because they understand what they're entitled to, the benefits package. So that's something that we are going to do. Then we have to be able to detect it. So we are going to have people in the various facilities as well. Health insurance staff will be engaging closely with service providers. Then we are able to pick it up. And the last one is one that people really don't like to hear. That is the deterrence, sanctions. So we have been able to put together a certain sanctions regime. And we've gotten the commitment of the heads of the service providers across the country, Director General of the Ghana Health Service, the Executive Director, Christian Health Association of Ghana, the leadership of private health facilities. We've been able to get their commitment that, listen, we are going to apply sanctions. If we find out that you are charging out of pocket for services that are covered by the NHIS. And we're also going to play our part by paying promptly. You pay promptly. Hospitals have enough liquidity to fuel their generators and take care of all their overhead costs so that the insurance would actually run. So next week, the Minister of Health is most likely going to meet the heads, the national key stakeholders within this country, speak to them about the review tariffs and the positive impact that we hope or that we expect that it will have on out-of-pocket payments. That is by reducing it from 25% down further. Thank you.
Let me just ask a follow-up question to what I asked. I mean, there's always that tendency that sometimes providers may provide, quote-unquote, unnecessary services just to rack up their claims, all right? So, for instance, one of my pet peeves is that somebody goes to a hospital with a fever, they come back home with all sorts of multivitamins, cough syrups, antimalarials when they've not been tested. And I think all of these things add up in terms of the drain to the National Health Insurance Scheme. What are some of the mechanisms that you are putting in place to ensure that we limit some of these practices?
So thank you very. In developing the tariffs, we look at what is standard within the country. So we have the standard treatment guidelines that clearly specifies the treatment pathways and what medications you are supposed to give per any condition. So that is also part of our responsibility, quality assurance responsibility. So I'm very happy that we have pharmacist William Omane Jekum. He's with the Ghana Medical Trust Fund now, but he was head of clinical audit and compliance. So we periodically sample facilities, go around, and then look at what they are prescribing us against what has been diagnosed and compare it to what we have within our Ghana diagnostic related groupings. And if we find out that you do not meet those standards, you've had to upcode or you've charged more than you were entitled to, we deduct from the claims that we are going to pay you subsequently. And there's been instances where we've deducted 1 million, 2 million, 4 million cedis just because of this level of, I don't want to call it malpractice, it borders on malpractice. But most importantly, we think that we have to engage the Ghana Medical and Dental Council, the Nurses and Midwifery Council, the West Africa College of Physicians. This is a good place that you can also help with advocacy, so that we sanitize the practice and we make sure that we are more efficient. At NHIA, all the allocations that we have, there's something we call the medical loss ratio, that a quantum of our resources should go into payment of claims. That is our core responsibility. I think the standard across the globe is 90%. Last year we did about 56%. This year we are doing 65%. We are going to do 75% by next year, and we'll continue to focus on the business for which we've been established to do within this country. That is to provide financial protection to the people of this republic.
Okay, great. Oh, by the way, although you guys are all panelists, it's okay to ask yourself questions. It's fine. But let me ask Mr. Adom. You did say that the private health insurance currently covers about 5%. Pardon? About 500,000 persons. It's really like a drop in the ocean if you look at the population of Ghana. What are some of the policies that you think can be introduced that would increase that coverage greater than what you currently have now? Because this was 500,000 is like, I don't know if it's less than 1%. My math is bad, but it's really small. So what are some of the things that you would recommend that would be able to increase your coverage?
Thank you very much. To an extent, if you look at 500,000 out of 34 million, then you would say nominally it's really small. The other, for us in the private health insurance space, we are buying healthcare cost at a certain level. And that level of cost that we are buying it at translates into a premium. And so if we need to increase the coverage for more people to come in, then healthcare costs must be brought to a certain level that will make it affordable for those people to come in. It is really, I know a lot of people say that insurance is about numbers. When you have more numbers, then you are able to cover your cost. When it comes to health insurance, it's a very different animal, because when it comes to health insurance, once your numbers increase, your claims go up. So if increasing the population is going to increase the claims, then you need a lot more premium to be able to pay for the claims. So it's all about affordability, and that's why I said that. To increase the coverage, for example, would require that currently, if you spread yourself too thin, based on the capital that is required to run a private health insurance in Ghana, you need to introduce more capital to keep yourself. So, for example, if NHIA, as the regulator, comes up with policies to say that, we want you to be able to increase your coverage. So in increasing the coverage, we are going to drop certain matrices for those who look at, say, the informal sector. That is one way to look at it. The second way to look at it, I was listening to Dr. Dzokoto in this tariff development, and one of the metrics you mentioned that was used in the calculation is the cost of operations of the particular service providers. Almost all our providers that we use by law are credentialed by the NHIA, and most of them, even though are in the private space, have some contracts with the NHIS. So it means that the cost of operating those facilities have been catered for in the NHIA tariff. So adding a margin to serve in the private health insurance space would be a good ground to be able to bring cost to a certain level that is moderated, and then this will translate into premium, which will be affordable for a lot more people to come on board. So I believe that, one, the tariff regime has to be looked at. That's number one. Number two, the legal framework has to be looked at from the capital adequacy ratio I mentioned, and then also making private health insurance compulsory for certain segments. If that doesn't come in, then there wouldn't be any incentive to really get more numbers. Yeah.
Right. Prof. Boima, I mean, obviously, with what you do, you are seeing the tail end of problems that are associated with complications of diabetes, cardiovascular diseases, hypertension, and all that. From where you sit and from what you've heard, what recommendations, apart from what we've already heard, would you give to the Ghana Medical Trust Fund, which I believe will largely be who your patients will be ending up with, and the National Health Insurance?
So thank you very much for the question. From where I sit as a clinician, or for all clinicians here, our goal is to see the patient well. Our goal is to see the patient smile. Our goal is affordability, accessibility to healthcare as much as possible. So if the fund is sustainable in the long term and people can afford healthcare based on what they are providing, services they are providing, that's really what we want as clinicians. So people don't come to the, refuse to come to clinic because they don't have transport, because they don't have money to do lab tests or buy medications here and there, etc. Or people don't have to travel far before they get healthcare. And if they can get healthcare in the region where they live is really what everybody wants to see, because healthcare is a fundamental right issue, and it borders on issues of whether it's affordable, whether it's accessible, etc. And I think that, just like Dr. Sedo said earlier on, somebody must pay for it. And where is that money going to come from? Whether it's the COVID-19 levy redefined or modified, the healthcare practitioner doesn't care. They just make sure that the source of funds is sustainable. That's all we care about. So wherever you get the money for, we don't care. It must be sustainable. That's what we want. So if you redefine the COVID-19 levy and the whole Ghana accepts it because now you made a case for it, we don't care. It must be sustainable. Whether it provides funds enough to support the GMTF, we don't mind. So, my friend, whether you like it or not, if you introduce a new tax today, people will still kick against it and discuss it in the media. There will be people who will still oppose it. There will be people who will still support it. If you redefine the COVID-19 levy, people will still discuss it. There will be people who will support it, people who will still oppose it. So whether it is there or not, people will still, there will be a lot of people who will still accept it. So, I mean, wherever the funds is coming from, as long as the program is sustainable in the long term, that is what the clinician wants to see. So my recommendation is, number one, a sustainable source of funds that can make the GMTF work in a long term. You don't start today, and then in the next 2 years, you have to stop, and then the patients are left on their own. That is not going to help anybody. You are providing specialized care for chronic conditions, complications of chronic conditions. Imagine you end up paying 56 Ghana cedis per capita. That is woefully inadequate. It's not going to help the patient in any way. And all clinicians in the room here can tell that for a fact, that is not going to help even sustain the cost of hypertension care alone in the long term. That's not going to be. So we need a sustainable source of funds that will make the scheme work. We need to enhance the new existing NHIS, the free primary care program that would decrease the burden of specialist services the GMTF has to produce. Because if you catch the NCDs early, you treat them very well, you will decrease the number of patients with the kidney diseases, the strokes, and the heart failures that GMTF would have to handle in the long term. Thank you.
Thank you very much, Dr. Prof. Boima. Well said. And Dr. Kipo, I'll come to you. But before then, let me ask Dr. Sedo, in your view, what is the biggest economic risk that could derail this whole universal health coverage progress, and how do we mitigate against it?
Why do I get all the difficult ones?
Because you are the health economist.
I think it's the biggest risk is when government tries to do all. That's the biggest risk. Because government cannot do all. It has to find a way of raising resources. It has to raise the resources from its own people and within its own productive sector. And there is a certain limit to what you can do within a certain time space. So one of the biggest risks is government being over-ambitious in achieving certain targets. So it needs not to over-promise. The other big risk is the issue of medical inflation. Until we get a certain efficiency ratio working in reining in the markets and being able to get that dividend out of the market and plow back into care, we risk not achieving it. That's the one. So I'm happy to hear that Dr. Dzokoto said we are trying to claw back some of those things by reducing fraud, reducing the leakages in the system. But that's a major risk. But a third risk for me is the regulatory framework in the system, which needs to open up the space for multiple players, like the private health insurance schemes, so that they can take some of the burden off government and handle it through a market efficiency, the market operating efficiently where it can. And when it fails, then health insurance and other social protection mechanisms step in and capture that market failure. At the moment, we seem to be buffing in both. And we need to look at that. But Dr. Boima has already spoken about one risk, and he has been very passionate about that. That as for us, the providers, we don't care. We just want our money when we need it and provide the services when the services are needed. Which is something that he said that sound in passing, but if you remember the three framework I told you about, that is something that he has reiterated in that simple way. That one, if you want me to provide specialized services or any other service, just make sure that you guarantee the demand so that I can plow back my investment. That is what he's just saying. If he were to go into private practice, let him plow back his investment. If he's in government sector, give him enough resources to maintain the facility and continue to get it. I hope that, and I recommend to the purchasers, insurance, national health insurance, now the Ghana Medical Trust Fund, to start thinking about whole area contracting. Okay, so that the providers will be confident and comfortable that they can break even on the resource framework. And then give space to those who can afford contribute into the framework. I guess those are some. There are a lot more, but I guess we can look at that.
Thank you very much. Do we have questions from the virtual audience? And then I'm coming to the audience. If anybody has any question, kindly raise your hands up. A microphone will be brought to you, and then do I see any hands up? Okay, a few hands are going up. Can we have microphones sent to them? And whilst the microphones are being sent to them, Dr. Kipo, we all agree and we all understand that the GMTF is a political creation. Yes? How are we going to guarantee that, and it's a good thing, how are we going to guarantee that we perpetuate its stay and it doesn't become, as we say, political football? Somebody comes and kicks it out, somebody comes and brings it back in.
All right. Thank you very much for the question. If your statement that the Ghana Medical Trust Fund is a political creation is from the fact that it was instituted by a government, then virtually almost every policy would say it's from a political creation.
So let me clarify. You know it is also called Mahama Cares.
Right.
And I'm just re-echoing what other people think about it, and that's the reality on the ground.
Sure.
So you know how things work in this country. Let's not mince words about it. People have this perception that because it was something that was started by one political entity, it is not likely to progress to the next. But it is a good thing. We all understand that it is a good thing. We would want to make sure that it perpetuates its stay. So my question really is, how are you safeguarding it, or to ensure that it's
So the official name of this entity is the Ghana Medical Trust Fund. First of all, it was established by law. So it has legal backing, Act 1144. But again, the fact that something is established by law does not mean it cannot go. It can go again by law, just like the COVID-19 levy. So that's the first one. One way we can guarantee that the Ghana Medical Trust Fund would remain, even with a change of government, is how efficient it runs and the impact it makes. We have had interventions that have come in, instituted by certain governments that have become like a political football. Classical example is free SHS. When the impact is felt by many Ghanaians, then it even becomes a crime if you threaten to take it off. So one way we can guarantee that the Ghana Medical Trust Fund would continue to exist, even with a change of government or with a change of a president, is how effective it is and the impact it makes. If, for instance, the Ghana Medical Trust Fund, say, is paying the bills for all cancer cases, just by way of example, and is doing so very efficiently, doing so in a very timely manner, and all the patients who have, say, breast cancer, prostate cancer, cervical cancer, have their chemotherapy, radiation therapy taken care of, I think it would be a disservice to any government that wants to take this off. Politically, will not even inure to their benefits to want to take it off. So it's a collective responsibility for all of us. If we want the Ghana Medical Trust Fund to stay, we have to show that commitment, and we have to make sure that this works and all Ghanaians benefit from it. Then it becomes a system that nobody wants to touch. And even if you have to touch it, your promise is to make it better and to enhance it.
So in essence, at the partner eton.
Exactly. If we do it well, we will stay.
Let me go to the audience. Question. Yeah, go ahead. Yes, can you introduce yourself and ask your question? And please keep it short. Okay. I think we've really stretched our time, so we need to be wrapping up.
All right. My name is Esu, a student of the University of Ghana Medical School. I have a lot of questions, but let me just make it one. This is to NHIA and then maybe the health economist. What's preventing us from increasing the premium, apart from political stuff? Because I feel like at times you go to the hospital, you need to do certain labs, but you cannot afford it. But what about NHI having different packages? Okay, maybe if you pay 100 cedis a year, when you come to the hospital, you can have a CT scan, you can have an MRI done. Instead of everybody paying the 23 cedis and then we don't get enough here, let me put it that way.
Okay. Right. NHIE and health economist.
Yeah, and please let me add this one. It's very important. Is is the NHI making any investment into rehabilitation? Because of late, a lot of people are smoking, and very soon we may have too many crazy people on the streets, and the cost of
I'm sorry, when you say smoking, is it cigarettes or
yes, cigarettes, shisha? Yeah, we have a lot of smoking going on. And rehabilitative medicine is quite expensive. If you have somebody who goes for psychiatric care, I'm sure a lot of people bear with me, it's quite expensive. How much is the NHI willing to go to cover some of those services?
Okay. I'm sure there are some psychiatrists who disagree with you that smoking weed and all those things leads to psychiatric abnormalities. But I also found it very interesting that yes, I also found it very interesting that in Dr. Combat's presentation, he said after hypertension, the second is respiratory illnesses or from environmental pollution, which sort of speaks to it. So can you address the question?
Right, Betty. Okay. So, thank you very much. Those were very brilliant questions. So when you look at the breakdown of the income to the National Health Insurance Scheme, the National Health Insurance Fund actually gives us more than 90%. Then SNIT contributions also gives us close to maybe 6-7%. The premiums give us about 2% every year. We actually do not want the payment of the premium to be a barrier for getting financial protection. That has been the only reason why we have not increased the premiums over time. It will interest you to know that even as low as it is, people are struggling to actually pay those premiums. So until we get to the point where it is not a barrier, then we could look at increasing the premiums that we charge from people. There's actually people who also advocate that let us even take off the premium. It's 2%, 3%, so that you have a lot of people with financial health protection. So that debate is also there. But we are not increasing it because we don't want it to be a barrier for our forward march to universal health coverage as a country. Now, the benefits package for the national health insurance is not static. From time to time, we add on. Dialysis was not part. We added it. But now it's going to the Ghana Medical Trust Fund. Cancers were not part. We've now added the four most common childhood cancers. We've added prostate cancer. We've added breast cancer. And now with the advent of Ghana Medical Trust Fund, we'll add more. Mental health was generally not covered. Now we've added schizophrenia, we've added bipolar, we've added anxiety disorders, and we've also added depression. At least 4. So with time, I'm sure that we'll be able to also look at rehabilitative care. But what we want to do in addition to that, the investment in preventive and promotive should give us enough returns. So when we are able to advocate seriously against drug abuse, which is actually endemic in our country now, we'll be able to prevent the complications of it. So we are not only looking at waiting for the complications to deal with, but we have to look at preventive, promotive as well, and then provide financial protection for curative. You've talked about rehabilitative earlier, and also palliative, because as the population ages, we have to, people would get to that stage of life where they will need that palliative care so that they can, die in peace or in comfort. Thank you very much.
I think we have time for one more question. Yes. I apologize that we've not had enough time for questions from the audience, but we can still take the questions and then we'll send it to them.
Sure. Thank you very much. I'm Salumi. I'm a final year medical student in University of Ghana. My first question, we are all talking about sustainability and a funding gap. I wanted to know if we as a country have an opportunity exploring corporate world, as in, let's say some companies that are in more than or above a certain revenue cap get to contribute to the National Health Insurance Scheme as their corporate social responsibility, and probably get some tax reductions or a few things here and there. That's one question. Another question is about the Ghana Medical Trust Fund, if there are any plans to invest some of the money that you'd be getting for the Ghana Medical Trust Fund into an interest-generating asset, so that it's not always we need to receive money, we need to receive money, we need to receive money. Thank you very much.
Okay. So Dr. Dzokoto and Dr. Kipo, quickly, in few sentences, there's an... Oh my God. I think we are getting more questions.
Yes.
Interestingly from students, right?
Yes, please. So I would like to say thank you very much for the opportunity. So my name is Andrew, I'm a medical student. So my question is very simple. The whole conversation about NCDs, non-communicable diseases, are we perhaps looking at it from the wrong angle? And I'm going to make my point in 5 points very quickly. So in the sense that we are looking at solving the problem not from its roots, but more at the end of it. So we are standing at the point where we are saying, for example, Jon Snow. I'm sure I'm familiar with the example of Jon Snow. We are standing at the point where we are looking for funding to buy cholera drugs or oral dehydration salts, when we should be looking for the tap that is causing the actual cholera. What's the point? That's the point I'm trying. Maybe we are looking for looking at the conversation from the wrong angle. So from the GMTF example, imagine a GMTF that was 80% preventive instead of 100%, should I say, curative, which is not necessarily even curative because NCDs are lifelong. So that's also the third point. Is this sustainable? We are talking about comprehensive healthcare. Is this sustainable in this sense? Because in the next year, it's going to increase by 5. In the next year, it's going to increase by 10. Rather looking at a solution where we are tackling the problem from the root, where we are guaranteed that in the next 5 years, our costs rather even going to reduce. I don't know if you are getting my point. And the last point is that it's going to be more cheaper, in the sense that if, let's say, we are pioneering health education, and we are saying that, I'm just giving an example of the back of my head, we are saying that all broadcasting corporations, every day of your broadcasting this thing, you are mandated to broadcast maybe 30 minutes of something educative, something that is telling the people that this is the direct cause of kidney disease. This is why you are going to get, and this is what's going to happen to you. This is the outlook if you end up getting a chronic non-communicable disease. This is what is going to happen. It's going to be, in the end, be more effective in curbing our cost and affecting our finances in our health sector. Thank you very much.
Okay. Thank you very much. You said you're a medical student, right? Which institution? University of Ghana. I look forward to seeing you. What's the next question? Somebody else had a question. That's it. No, yeah, sorry, the lady in... Yeah.
Thank you. So I'm Harriet from the Ghana Medical Trust Fund. I have a question for, I don't remember his name, so I'll say the tax guy. So I did taxation not too long ago for a prerequisite for my master's, and I learned that there are 2 types of taxation. There is the tax deepening and then tax widening. And if you say we should introduce COVID-19 in a reformed way and tax it for the Ghana Medical Trust Fund, which will be a good thing for us, it would be widening the tax. But in taxation, it's believed that deepening tax is better than widening tax. And there are some taxes already out there that prevent people from consuming things that will give you the illness that we are already trying to raise funds to prevent. So instead of bringing a new tax, we can deepen that tax that would discourage people from consuming the products that will bring the illness, that will now have to go and look for money to come and fund. And also with the NHIA, we can also deepen that tax and tell Ghanaians that we are using the money to do this and that and that. And people are more prone to give out their money if they can see results for it. At least that's what they said at taxation class. So my question to you is, would you agree that we should rather deepen the tax instead of widening the tax?
Okay, thank you very much. So that will be our last question. So let me let Dr. Dzokoto take the student's question quickly, and then Dr. Combat can come in, and then we wrap up.
Yes.
So quickly.
Thank you very much. I'm so excited that we have future leaders coming up here. The doctors are really brilliant. And let me begin with John Snow, as I've nicknamed him. So the suggestion for exposure for more advocacy is very good. To be able to actually have it as mandatory for all our radio station, TV stations to have like a certain time where they speak about certain preventive health interventions would be great. As a country, we have so many laws. If you go to our local assemblies, there are so many bylaws against sanitation, but enforcement has usually been the challenge. And globally, if you look at cigarette smoking and its complication, now when you even pick the box of the cigarette, you see that they've drawn all those things. So it's evolution of policy over time. It's come up. But let me say that we are actually investing quite a lot into preventive promotive now, especially with the free primary health care that is coming. We are going to be looking at screening. In my presentation, I talked about it. Screening for hypertension, screening for diabetes, screening for cancer. So we pick it early, then we are able to reduce the incidence of those diseases. Then economically, we reduce the burden on the national purse. So it's the trajectory. And I'm happy that you are thinking like this already. We are in good hands in the future. Then the corporate social responsibilities. There's no legislation that forces companies to actually use part of their profit for corporate social responsibilities. Again, it's a brilliant idea. Maybe it's something that we should look at. It's a free market economy. Dr. Sedo, I don't know whether we'll be able to impose this on the big companies, big pharma, those who appear to be making a lot of margins. If that was possible, why not? Let's trigger that discussion and see what happens. But overall, I'm very excited that our future leaders are really thinking in the right direction.
So am I. Dr. Combat, you want to answer the last question?
Okay, so you are right. It is always good that you have a tax that will discourage consumption of goods that are said to be harmful when they are consumed. And so when you have a tax of that nature, it serves, let's say, about 4 purposes. So first one, we call it win-win-win. There are 4. So when you have such a tax, the first win is it is going to generate revenue. The second win is that it is likely to discourage consumption of the product. So for instance, if you impose tax on alcohol, the price goes up. That is why we say you have internalized the tax. So the price is likely to go up. So if you were drinking, do they call it tot? If you were drinking 2 tots, because that become expensive, you then decide to drink only 1 tot. Yeah, so that is the second win. And then the third win, we are talking about, you try to reduce healthcare burden. You know, I showed you a graph, and the graph was per capita expenditure on every individual, and WHO says it should be 86. In Ghana, it was higher. What it means is that government is spending a lot on every individual. So when you impose that taxes, you are trying to reduce the healthcare burden. And of course, the last one is the NCDs, the risk associated with the NCDs. So you are trying to reduce that as well. So you are 100% correct. If you introduce health taxes, one of the objectives would be to discourage consumption of the product and then reduce its consumption totally. And then your question on deepening and widening, they are the same. Yeah, they are the same. So widening and deepening, they are the same. But you see, we like imposing such taxes on goods and services that we consume, and therefore we call that consumption tax. If you impose consumption tax, we like it. Why? Because even children yet to be born pay the tax. That is indirect tax, it's VAT. And so whether you are adult or not even yet born or child, so far as you buy a product, a taxable product that has the VAT, then you have to pay. So that is why we always go in for such products that like almost everybody consumes, and therefore you consume and then you have to pay the tax. So we chose VAT because it is a consumption tax. You getting it? And that widens the coverage, and everybody buys the product, and therefore the revenue increases. So
Okay.
when you look at the NHIL, the National Health Insurance Levy, is 2.5% of taxable commodities. If you took the COVID cancelled, the one that we just cancelled, it is 1% of taxable product. It's very good because you impose it on goods that are consumed by a lot of people. Thank you.
Okay. So, Dr. Sado, final word.
Okay, quick one. Yes, I agree with consumption tax. It's important how you deepen consumption tax, but you also have to understand the kind of product and their sequencing. So if you, for instance, for public health, you say alcohol is not good, right? But akweteshi is not drunk by the affluent. It's not really the affluent. So if you put a tax on akweteshi, it's going to be regressive. Do you understand? The people don't quit it that quickly. It's the same reason we don't go for sugar taxes. Because even though we all know that sugar contributes to diabetes, but if you put it on it, the poor are going to bear the bigger tax burden than the rich. Because they can go for alternatives. There are alternative goods on the market, but these ones can. By the same way, you can go for whiskey, then that is up. So that kind of sequencing is what we do in taxation. Especially for public health taxation, you have to do that kind of sequencing. Now, there's this thing about the Ghana Medical Trust Fund, okay, that assumes that it should focus on preventive rather than the curative. That's where you are going, okay? But there are many of the conditions that are not lifestyle. Sickle cell, okay, it's a life cause. That's a major issue. Cancers. The highest right now is childhood cancers. And the youth, the under 30s, that's the biggest that we have currently. That's not life cause. Do you realize that? But it is lifetime. That's not a lifestyle, but it's life cause. So the fund must be looked at from that perspective, where it now impoverishes the whole household because the child has cancer, and suddenly it equalizes poverty even for the richest people because it is life cause. That is where the health perspective has to come in. You get that now? So it's not always the lifestyle that causes the NCDs. Some are simply genetic and some are just incidental. We don't know how. And somebody needs to pick that. If you put it on health insurance, then you are taking away from the primary care and the basic secondary care, which you look at the lifestyle and progression framework. Someone needs to take what is falling between them and not make the burden too heavy from the general population. So intervene as the incidence point and not at the prevalence point. And that is why the Ghana Medical Trust Fund is very important. Okay. You get that framework?
Yeah. Thank you very much. I think my panelists have been very brilliant in answering the questions. A round of applause for them. But before I end, there's a single question for all of you. I just want yes, no, yes, no, yes, no. Is universal health coverage attainable by 2030? Yes, Dr. Kipo, yes or no? Yes, Dr. Dzokoto. Prof. Boima. Quick, yes or no? You don't know. Dr. Sedo. If you can find $18 billion, then it's a yes. Dollars, you mean? Okay, Mr. Adom. Mr. Adom, yes or no?
My regulator says yes, so I go.
He's dodging the question. Dr. Combat.
Okay, so coming from...
It's a yes or no?
Yes. No.
Yeah. Okay. I think that's a round of applause. Oh, please, I think we need to take a picture. Prof. Boima and Co, come. Prof. Boima and Dr. Combat, please sit down. Let's take a group picture. I think that this has been, we should stand. This has been a very wonderful session. Our panelists have been very brilliant. We thank you very much for your contributions. And Mr. Chairperson is coming to give his closing remarks, but we'll take a quick picture. And then, please, the camera is over there, so let's all look into the camera. Thank you very much. We would like to invite the Vice President of the college. Please do not go yet. Vice President of the college, please come and join us, take a picture as well. And once again, yes, it's unfortunate that it's an all-male panel. I think that next year we'll mix it a bit and have some gender balance. Okay. Yes, please, can we take the picture? Are we balanced? Yes. Thank you very much, everyone. There's another shot. Oh, sorry. Thank you very much. And whilst Prof. Chair gets ready to give us his closing remarks, we'd like to recognize the presence of the President of the Pharmaceutical Society of Ghana, Mr. Donko, please. The pharmacists are very important in what we do as well. Thank you very much.
Thank you very much, ladies and gentlemen. I believe we've had a very exciting evening. So can we give ourselves a round of applause for being such brilliant audience. I did a comprehensive summary. I'm not going to go through that because of the time, and we spent so much time already. We are indeed very grateful for all our speakers, starting from the keynote speaker, WHO, and then our rep from the Ministry of Health, very grateful. And then we also had initial thoughts from our speakers, the panelists as well, and we are very grateful for all that you discussed, the health economists, the clinician, the Ghana Medical Trust Fund. We also had NHIS, private health insurance, and Ghana Revenue Authority. These brought into perspective all that we hope for to achieve. To me, and for us, I believe the key highlight of this evening is that there are gaps in health care financing in Ghana. So those are the messages I want us to take away. And that political will could improve domestic revenue mobilization for health care. That importantly, we need to improve efficiency and reduce leakages in the system. That's what we call allocative efficiency. Whatever little we get, we need to use it effectively to achieve the intended goal. We also had very insightful discussions on taxes as to whether to bring back some taxes or use existing taxes and channel them into areas. We also looked at tariffs, and that increases in tariff does not necessarily mean a person going into the health facility is going to pay more, but rather health facilities providers may receive more for the services they provide. And also the role of the private insurer, that we need to get them involved. And one key note from Dr. Seda was that the key risk will be if government tries to do it all. I think we need to highlight that. May be politically expedient, but we need to tread cautiously so that we don't put on so much and we will not be able to. For the current health policies and architecture, I believe we are in a very good place. The free primary health care will deal with most of the preventive, promotive aspects, the screening, getting the diseases diagnosed early. What we must understand is that we need to do all this. However, there are people already in the system with the complication. So we cannot only focus on primary health care. There is need to have some sustainable funding for dealing with those complications. And therefore, it is important that we have the national health insurance as a second tier, which will then take care of the basic curative aspect of things. And then those who have the complications or who develop the complication will be tackled with the Ghana Medical Trust Fund, which would then reduce the catastrophic cost, which pushes families into poverty. If any of us here may be middle class, upper class, I can tell you, if they admit a relative into the ICU and you have to buy Meronim for a week or 2 weeks, then you see that, yes, really, it's not that easy, and that you need, if there is a funding. Dr. Kipo is nodding. Yes, we really need that. My personal advocacy will be from this evening is that we may not want to push every responsibility on government, and therefore the advocacy is that corporate institutions like universities, like teacher associations, like nurses, let's develop other mutual health financing schemes. Every month, if you pay 100 cedis, 150, 200, and that can go beyond what NHIS can do, that will help sustain the Ghana Trust Fund, Ghana Medical Trust Fund. We need to look at that. Recently, we're trying to push that agenda in the university, and there's so much resistance. How do you expect that you and your family will always be taken care free? It is not sustainable, and the advocacy is that let's help government, let's help the Ghana Medical Trust Fund. Teachers, nurses, corporate agencies, universities, driver associations, all that. We can have this tier just above the national health insurance, and it may help all of us. So I believe having comprehensive health care financing is possible and could be a reality if the financing is coherent, as we've talked about this evening, if primary health care is made a priority so that we prevent a lot of the cases, and evidence-informed policy is what we use to move forward to determine our tariffs and to determine the disease burdens and all that. And finally, again, to reiterate, government avoiding trying to do it all and bring private, corporate, and other agencies on board to support. Ladies and gentlemen, thank you very much for such a brilliant evening.
Thank you very much, Prof. Yawson. Once again, we would like to say a big thank you to the audience for staying with us, being very engaging in our interaction this evening that has now turned to night. We've made some arrangements for some refreshments, and there's no co-payment attached to it, so please enjoy. I'd like to say a big thank you to Casapreco for refreshing us this evening as well. They've been very kind to us and giving us the drinks and the waters that we are enjoying today. So thank you very much to Casapreco. Hopefully you do not apply some alcohol tax to their to their products. So finally, let me quickly invite Dr. Collins Kokuru to give us some short announcements with regards to the upcoming West Africa College of Physicians. What is it? It's the annual program, right? Next year. Yes, so short, quick one.
Thank you very much, and good evening to everybody. Good evening, my VP and past VPs. So, the West African College of Physicians is 50 years. 50 years. So, 50 years of a college shaping, yes, 50 years of the college shaping health education, health promotion, and everything health West Africa. So, next year, 2026 is 50 years, and we are going to have a West African program and also a national program. And so the national program is going to happen here in Ghana. We are anticipating that to be around June. You hear of us. And so we are going to call on all of you, Ministry of Health, NHIA, Mahama Care, even Ministry of DRA and everybody to come so that we can have a comprehensive program towards comprehensive financing of all aspects of health for everybody. So we are going to be sending the invites and other programs to you, and we hope that once again you come and help us to make this big for the college and also for all of us. Thank you very much.
Thank you very much, Dr. Kukuro. And on that note, with the permission granted to me by the Vice President of the College of West Africa College of Physicians, Ghana chapter, and our chairperson, Prof. Yawson, I bring this encounter to an end. Please go home with the peace of the Lord, and may you have a beautiful night. Thank you very much for coming once again.